Okay, so welcome to the next module. This module is starting on chapter 27, and then it's going to be chapter 30 and 31. And we're going to talk about cardiovascular diagnostic tests to begin with, and some therapeutic procedures. Okay, so like the other modules, there's going to be just some topics that I'm going to talk about at the beginning, and then we'll go into them in more detail. Now, I know the two respiratory modules were quite long. I'm going to make an effort to reduce the length of time for the following modules, okay? So hopefully you get lots of information out of this. Okay, so let's just talk about a few topics first, and then we'll get into the module, okay? I find if we just do a review of some of the terms, it helps understand the module much better. Okay, so cardiac enzymes, what are they? Well, we do blood tests to see if we can detect cardiac enzymes in the bloodstream. And if cardiac enzymes are elevated in the bloodstream, it means there's been some kind of myocardial injury. Okay, so whether that's a myocardial infarction, a heart attack, or inflammation of the muscle of the heart, say myocarditis, which is just inflammation of the heart muscle. Typically, we're using cardiac enzymes to diagnose a myocardial infarction. Okay, so what kind of cardiac enzymes do we rely on typically? The most common cardiac enzyme that we use now is troponin. Okay, by far, it's the most common cardiac enzyme. And if someone comes in with chest pain, we're going to take blood for a serum troponin. And if it's elevated, because it's such a specific test, that indicates that there's been myocardial damage and an infarction, either an end-STEMI or a STEMI. Okay. Now, if someone comes in with stable angina or unstable angina, do they have elevated troponin? No. If someone comes in with an arrhythmia, an irregular rhythm, and we do a blood test, the troponin is negative, have they have a heart attack? No. Okay, so usually an elevated troponin signifies a heart attack. Okay, we used to use different cardiac enzymes. We used to use creatine kinase, CK. Okay, and that was a marker that we would use, creatine kinase, and MB was the cardiac portion of creatine kinase that we have in our bloodstream, and that type of creatine kinase was released from heart muscle. Okay, we don't use it very much anymore. Okay, we really use what's called troponin T or troponin I. Okay, and usually after a heart attack, these typically start to rise in 2 to 3 hours, and troponins can stay elevated for about 7 to 14 days. Okay, so even after someone's had a heart attack and they come back a week later, we may still be detecting an elevated troponin in their bloodstream. Okay. Creatine kinase, the older one, sure, it also goes up in a heart attack, and it typically only lasts about 2 to 3 days in the bloodstream. There was another one that we used to use called myoglobin, again, just another enzyme released by the heart, and that would be elevated in a heart attack, and it would only stay up for about a day, 24 hours. Okay. So really try to focus on troponin as the most important cardiac enzyme. Okay, I'm not really sure why cholesterol is bunched in with cardiac enzymes, but cholesterol is just a risk factor for heart disease, just like it's a risk factor for strokes, because elevated cholesterol is a risk factor for developing atherosclerosis in the arteries of your body. So whether it's a heart attack, a stroke, or peripheral vascular disease, elevated cholesterol has been linked with more plaque formation. Okay, so in terms of cholesterol, we don't test for cholesterol if someone comes in with chest pain. We're doing an ECG, we're doing troponins. Okay, so just see cholesterol as a risk factor, just like smoking is a risk factor, or sedentary lifestyle is a risk factor. In general, we like to see total cholesterol less than 200 milligrams per deciliter. The LDL, so low density lipoprotein, which is a portion of the cholesterol that we can call bad cholesterol, it is typically less than 130 milligrams per deciliter. That's where we like to see it. HDL, which is termed good cholesterol, so an elevated HDL is actually beneficial. It's been shown to reduce the incidence of atherosclerosis. Okay, and we usually like to see that greater than around 45 to 55. So 45 in males, we want to see it greater than that, and 55 in females. Okay, so just note, HDL, good cholesterol, I want to see it high. LDL, bad cholesterol, I want to see it low. Triglycerides are also a risk factor, and when they're elevated, they're also a risk factor for atherosclerosis. Okay, so don't get confused here. Cholesterol is just for long-term risk of atherosclerosis. Cardiac enzymes is to look at today. Has there been a heart attack today? Okay. Okay, a transthoracic echocardiogram is just what it says, transthoracic, so we go through the chest. And it's a probe that goes on the chest, so an ultrasound probe, and we're looking at the chambers of the heart. We're looking at the pumping of the heart. We can see the valves with an echocardiogram. And we can see if someone's had a previous heart attack because that portion of the muscle isn't pumping anymore. Okay, so all kinds of information can be obtained with an echocardiogram. The size of the chambers, what the valves look like, the strength of pumping of the heart can all be used with a transthoracic echocardiogram, and they're easy to get, right? So typically it takes about 45 minutes to an hour to do this test. They're typically lying on their back, and then they roll over to the left side to bring the heart really close to the left chest so they can get a good view. Okay, what about a transesophageal echocardiogram? So same thing, we're getting a view of the chambers of the heart, of the valves of the heart. We can look at the pumping of the heart. We can look for blood clots within the chambers, say such as in atrial fibrillation. The one advantage of this is that it gets the probe really close to the heart. How do we get that close to the heart? You have to swallow the probe in your esophagus. So the probe goes into your esophagus, and right in front of the esophagus, once we get to a certain level, is the heart. So it's just a close-up view. Okay, so we can still look at heart failure, so the pumping of the heart. We can get really close views of the valves. We can look at clots in the atrium or the ventricles. So really it's the same thing. It's an ultrasound of the heart, right? We just want to get a much closer view. It's a bit more invasive though because the probe has to go into the esophagus. So typically these patients need to be NPO prior to getting this so they don't vomit while this probe is going into their esophagus. Okay, so there's different types of stress tests. So what's a stress test? Well, it's going to be either an exercise stress test where we're going to have a patient go onto a treadmill and get them to walk faster and faster and faster while they have cardiac monitor leads on their chest. And they have to typically reach a certain heart rate, a maximal heart rate for their age. And we're looking for changes on the monitor that may indicate a blocked coronary artery. Okay, so as we stress the heart in terms of getting the heart rate up faster, sometimes we can see changes on the monitor that may indicate that there's not enough blood flow in the coronary artery. So for example, angina, we may diagnose unstable angina, or some arrhythmia may occur while they're on the exercise stress test. Okay, so how do we do this? Well, they're going to be walking on a treadmill, right? So we usually advise them to wear comfortable shoes and clothing um, for the stress test. Now, many people can't do an exercise stress test, either for, say, they're very elderly, they have osteoarthritis, they can't walk for that long. So there's many reasons why someone can't have an exercise stress test. So instead of getting them to exercise on the stress test, we can inject them with some kind of a stimulant to get the heart to speed up. So there's medications such as dipyridamole, adenosine, dobutamine. They're going to get the heart rate up. Okay, so it basically mimics an exercise stress test. They just don't have to exercise. Okay, typically patients are going to fast 2 to 4 hours before the procedure. They're going to be requested not to smoke or take caffeine or alcohol prior to the test. Again, they're attached with monitors, with leads, that go to a monitor to look while they're being injected with these medications to see if there's any changes on the ECG that we'll talk about in an upcoming module, to see if they have arrhythmias or if there's changes on the ECG that show that there's potentially blockage in the coronary arteries. Okay? So after that procedure, the patient will be monitored because they've been injected with a stimulant drug. Their blood pressure will be monitored, and then a report will be generated from the stress test. Okay, so there's exercise stress testing, and there's stress tests that we can obtain with injections of medication. Okay, let's just talk about invasive hemodynamic monitoring, meaning we have to put a central line in or an arterial line in to get very accurate readings of what's going on in different parts of the venous system or the right side of the heart or the arterial system. Okay, so these are typically in very sick people. Okay, we don't do this routinely on patients that are coming in unless they're critically ill. So say someone has severe heart failure, or they have, say, acute respiratory distress syndrome, and they're in the ICU. We often like to monitor the pressures going into the right side of the heart and also monitor minute-to-minute blood pressures. So we need catheters that are inserted in or as a central venous monitoring, okay, or central arterial monitoring. So they're invasive, okay. So what can we monitor? So let's say we put a central line in. So whether it's the internal jugular vein in your neck, somewhere where there's a large vein, what can we monitor? Well, we can monitor just the central venous pressure. So that's the pressure that's coming back to the heart. Okay, central venous pressure. What else can we monitor? Well, we can put a probe in the pulmonary artery, and we can see what the pressures are in the pulmonary artery that the poor right ventricle has to pump against. A pulmonary artery wedge pressure is just a probe that goes further into the pulmonary artery and it wedges into one of the smaller vessels. Okay, so pulmonary artery wedge pressure, that's all it is. So these are all ways of just getting values of pressure from the right side of the heart. Okay, and we like to know that because someone who's critically ill will want specific pressures on the right side of the heart, and we can adjust that with medications and with IV fluids. Okay. What about a pulmonary artery catheter? Okay, so that's going to be a catheter again that goes into the pulmonary artery. Okay, so it came in from the right atrium, right ventricle, and was put in to the right into the pulmonary artery to monitor pressures, right? And it just gives us a good idea of how much IV fluids do they need, how much potential vasopressors, so stimulant drugs for the heart, will they need. Okay, so just gives us lots of information. Okay. What if we want to measure minute to minute or second to second arterial blood pressure? So that would be an arterial line. So typically done at the wrist or the femoral artery. So the radial artery at the wrist or the femoral artery. And this is going to give us minute to minute information on the systemic arterial blood pressure. Okay. And sometimes we need that in critically ill patients, just to monitor what their blood pressure is very, very frequently, compared to just using a blood pressure cuff. That doesn't give us as accurate a reading as an arterial line. Okay, so angiography is really just the study of a vascular bed. Right? So an arterial vascular bed. So if we're doing a coronary angiogram, well, we want to put dye into the coronary arteries and see the anatomy of the coronary arteries and to see if any of them are blocked. Okay? If we're doing a cerebral angiogram, we're looking at the arteries of the brain. A renal angiogram, arteries of the kidney. Okay? So we can do angiograms all over the body. We can do angiograms of the leg, looking for a blockage in an artery that's perfusing the leg. Okay, so I'm not going to go into the procedures and post-procedures and all that, but just understand what an angiogram is for. We're looking for potential blockages in arteries. Okay, I know there's a lot of considerations and intra-procedure and post-procedure. I'll leave that part for you, okay? Let's just talk a bit about some complications of an angiogram, okay? So for a coronary angiogram, they have to go into an artery, okay, whether it's at the wrist, so your radial artery, or at the femur, so the femoral site, and they thread a catheter up to the heart, and they spray in some dye into the coronary arteries, okay? And they have a catheter there. Okay, so what's the potential complications of having a coronary angiogram? Well, the artery could be injured. One of the coronary arteries could be injured, and what's called arterial dissection, where the wall of the artery dissects. And what can happen there is when blood gets behind the inner wall of the coronary artery, it starts to make a false passage, right? And it's going to occlude the coronary artery because the blood is dissecting into the wall. It hasn't perforated right through the wall of the coronary artery, but it's dissected within the wall, so it's going to compress the lumen. And that can lead to a myocardial infarction. So if there's aortic dissection, sometimes they have to quickly go on to surgery to repair the arterial dissection. Okay? What's the other possibility is that they could perforate through a coronary artery, and that could lead to cardiac tamponade, because now you have blood leaking into the pericardial space. You can get a hematoma at the insertion site, so at the wrist or at the feet, at the femoral area. A hematoma can form. So typically we monitor those sites. We put pressure on those sites to prevent hematoma formation. Okay. You can have allergic reactions to the contrast media. So anyone can have allergic reactions if they're getting it for the first time, where they're having basically an anaphylactic type of reaction, right? Chills, fever, urticaria, wheezing, tachycardia would be common signs of an allergic reaction to contrast media. Okay. Embolism. Well, okay, so if you're in the coronary artery and you're opening up a plaque or you're spraying some dye in, well, a piece of the plaque could break off and go further down the coronary artery, and that can lead to blockage of the coronary artery further down, and that could cause a myocardial infarction, right? Restenosis of a treated vessel. Well, if you're in the coronary artery and you open it up and sometimes put a stent across it, that whole area could restenose, could reblock up, right? So there's always a risk for that. Retroperitoneal bleeding is in the abdomen, so when they're putting the catheter into the femoral artery as opposed to the wrist, so it's not going to happen with the wrist, they could puncture the artery. And where will the blood go? Into the retroperitoneal space. Okay, so typically patients will develop hypotension because they have an arterial bleed in their abdomen, and flank pain. Okay, this is an emergency because an artery has been punctured in the abdomen. Okay, so pretty significant complication. Acute kidney injury is going to be from the contrast media because the contrast media can be nephrotoxic. Okay, so typically all they need is lots of oral fluids, lots of IV fluids, and we monitor the BUN creatinine, which is the function of their kidneys. Okay, so let's go on and do a bit of an anatomy review of the heart. We'll discuss some topics in health history, physical assessments for cardiac issues, and diagnostic evaluation. Okay, so let's do a quick flow through the heart, and we're going to start on the venous side. So blood is going to come back from the inferior vena cava, so the lower part of your body, the superior vena cava, the upper part of your body, and flow into the right atrium. Okay, the right atrium is going to allow blood to flow into the right ventricle through the tricuspid valve. So that's a leaflet valve. Okay. The right ventricle can then pump the blood into the pulmonary artery through the pulmonic valve, and that's a cusp type valve. Okay. And the pulmonary artery splits into two, left and right, going to the left and right lung. Okay, where it's going to get into smaller and smaller branches of the pulmonary artery until they become capillaries at the alveolar level to receive oxygen from the alveoli and get rid of the CO2. The blood's going to return to the left side of the heart by the pulmonary veins, which is now oxygenated blood. Okay, and that's why it's in red in this image. And it's going to flow to the left atrium. Okay. After the left atrium, there's the mitral valve. Okay. That has two leaflets to it. It's a leaflet valve. Flows into the left ventricle, which is the powerhouse of the heart, with a very thick muscle for pumping against systolic blood pressure. It's going to flow through the aortic valve, which is a cusp valve with 3 cusps to it normally, into the aorta, right? And finally, from the aorta, it's going to flow to all the different organs in the body. Now, you can't see the coronary arteries in this image. Their coronary arteries are on the surface of the heart. So they come off the first part of the aorta, and you have a left coronary artery and a right coronary artery. And then they branch off and go to all the different parts of the heart to feed the heart with oxygen and glucose. So remember, the right side of the heart is a low pressure system. It's the venous side, right? So blood is coming back to the right atrium from the veins. So very low pressure, okay? Even the right ventricle is not pumping into the pulmonary artery with high pressures. It's just not needed, okay? Compared to the left side of the heart that has high pressures. So once you get into the left ventricle, well, that left ventricle has to pump at pressures that can exceed the systolic blood pressure, or sorry, the systemic blood pressure to get blood into the aorta, okay? So what's cardiac output? Well, cardiac output is heart rate times stroke volume. So what's stroke volume? It is how much blood is being pumped out per contraction of the left ventricle. Okay. So for example, if the left ventricle pumps out 50 milliliters of blood and your heart rate is 60 per minute, well, in 1 minute, you're pumping out 3,000 milliliters of blood, or 3 liters of blood. That would be your cardiac output. Okay, so your cardiac output is totally dependent on your heart rate and how much volume that left ventricle is pumping out every time it contracts. So you can imagine someone with congestive heart failure and a really weak left ventricle. They can't generate a lot of force, so the stroke volume will be reduced and the cardiac output will be reduced because they're not pumping much blood out with every contraction. Okay. The concept of preload and afterload, I just think of afterload as the blood pressure that the chamber has to pump out against. So what's the afterload of the left ventricle? Well, it's the blood pressure in the aorta, because that's what it has to push the blood out of the left ventricle at that pressure to get it out of the left ventricle. What's the afterload of the right ventricle? Well, it's the blood pressure in the pulmonary artery, because that's what it has to force blood out of the right ventricle to get into the pulmonary artery. Okay. What's preload? The preload is really the pressure and the volume during relaxation of a ventricle. And what's happening during relaxation is blood is returning to the ventricle, say the right ventricle, as it's relaxing, and blood is filling the right ventricle, and it's stretching it, and it's loading it for the next contraction. So, for example, if you have no blood coming back from the inferior or superior vena cava, and so there's no blood flowing into your right ventricle, well, your preload is 0. Okay, so the preload is the pressure and the volume that's stretching the ventricle, getting it ready for the next contraction. Okay, and we care about that because there's some drugs that can lower the preload. There's some drugs such as nitroglycerin that can vasodilate the veins and really reduce the blood that's returning to the right ventricle and reducing the preload. So I think of the preload of a ventricle as um, the filling of the ventricle with blood, stretching the fibers of the myocardium, getting it ready for the next contraction. And if the blood doesn't fill the chamber, well, there's no preload. It didn't fill it properly. Okay. And the afterload is how much blood pressure do I have to pump against to get my blood out of the ventricle. Okay. Um, there's a note here at the bottom on the slide in terms of women developing coronary artery disease typically 10 years later than men. And that's true. Women develop heart disease and they catch up with men about 10 years later. And the reason for that is estrogen is very protective for the development of cardiovascular disease. So after menopause, where women no longer have any estrogen in their system, coronary artery disease becomes much more prevalent in women. Okay, and they actually catch up to men in terms of developing coronary artery disease. Okay, so let's do some questions at the back of chapter 27. Number one, a nurse is orientating a newly licensed nurse on the care of a client who is to have a line placed for hemodynamic monitoring. Which of the following statements by the newly licensed nurse indicates understanding? So it sounds like they're having an invasive line put in because it's for hemodynamic monitoring. So if it's through a vein, through a central vein, such as the internal jugular or say a femoral vein, we're going to monitor the pressures on the right side of the heart. If it's through an artery, so an arterial line, we're going to monitor the pressures on the arterial side of the heart, okay? Much higher pressures. So let's have a look here. Which of the following statements by the newly licensed nurse indicates understanding? Air should be instilled into the monitoring system prior to the procedure. Boy, I really hope not, because that means air is traveling to your heart, which will be an air embolism. B, the client should be positioned on the left side during the procedure. That's not true when you're placing a central line. In fact, the patient's typically supine, so flat, or in Trendelenburg, where the head's down a bit. Okay. The transducer should be level with the second intercostal space after the line is placed. The transducer. So the transducer is the machine that's monitoring the pressure. That doesn't need to be at the second intercostal space. Typically, the transducer is put at around the fourth intercostal space, which is supposed to correlate with the right atrium. Okay. A chest X-ray is needed to verify placement after the procedure. Okay, that's going to be the answer, right? So whenever a central line is put in, a chest X-ray is done to see exactly where the placement of the line was put. Because these lines have little markers on them. And when we X-ray, we do a chest X-ray, we can see exactly where the line got to. Okay, so that's the answer. Okay, I find with a lot of these questions, just look for the answer that makes sense. Do I need to do a chest X-ray after putting in a central line? Yes. Okay. Because a lot of the questions or answers sometimes don't make any sense. A nurse is assessing a client who is undergoing hemodynamic monitoring. The client has a CVP of 7 and a pulmonary wedge pressure of 17. Which of the following findings should the nurse expect? Okay, so if you go back to the chapter and look at the values of what we expect in terms of pressures on the right side of the heart, that will tell you whether they're high, low, or normal. Okay, if someone's extremely dehydrated, the right-sided pressures in the veins and the ventricle and the right ventricle and the pulmonary artery, they're going to be low. If they're high, well, that usually means that the person is well hydrated and something else may be going on. So let's look at the first answer. Poor skin trigger. No, these values are on the high side. So poor skin trigger wouldn't cause this. Bilateral crackles in the lungs. Sure. So if you have congestive heart failure from left ventricular failure, it's going to back up the fluid into your lungs. It's going to cause an elevated pulmonary wedge pressure. And it's also going to back up fluid into the right ventricle and right atrium, causing an elevated central venous pressure. Okay, so B is going to be right. Jugular venous distension. Well, that's just backup of blood in the veins. That one's going to be right. Dry mucous membranes. No, that's trying to indicate dehydration. No, these pressures are on the high side. D or E, hepatomegaly. Sure. If you have elevated pressures on the venous side, it's going to back up to the liver, causing hepatomegaly. So the answers are B, C, and E. Number 3. A nurse is teaching a client who is scheduled for a coronary angiogram. Which of the following statements should the nurse include? You should have nothing to eat or drink for 4 hours prior to the procedure. So typically it's 8 hours prior to the procedure. We don't always have that luxury if it's an emergency coronary angiogram, sorry. But if it's a booked angiogram, then preferably it's 8 hours. You'll be given general anesthesia during the procedure. No, that's not true. Often the patients are just lightly sedated, or they're awake for the procedure after having had some local anesthetic, so they don't need a general anesthetic. C, you should not have this procedure done if you're allergic to eggs. We often ask if they have an allergy to iodine or shellfish because there's contrast media being used, but not allergies to eggs. Okay. In fact, a lot of the newer dyes, the iodine and shellfish allergies are starting to disappear. Okay, we still ask iodine and shellfish allergies, but the newer dyes and contrast media, it's not as big of a deal anymore. D, you will need to keep your affected leg straight following the procedure. That's true. Okay, so after having a coronary angiogram, assuming you had one through the femoral artery, you need to rest in a supine position, okay, to stop any formation of bleeding or hematoma at the insertion site. So that's true. Okay, number 4. Nurse at a provider's office is reviewing the laboratory test results for a group of clients. The nurse should identify that which of the following results indicates the client is at risk for heart disease. Total cholesterol, 245. Yep, that's on the high side. So high normal is 200. So that's a risk factor. An HDL of 90. No, that's a good cholesterol. So the higher the better. Above 45 in males or 55 in females is good. So that's just fine. LDL of 140. So 130 is the cutoff usually. So that's going to be a risk factor, right? Because of an elevated, quote, bad cholesterol, which is LDL. Triglycerides of 125. No, that's still in the normal range, so that would be considered fine. And a troponin of 0.02. No, indicates it is at risk for heart disease. No, that's a bit of an unfair question because they're actually asking you values of troponin I. And different hospitals have different values, so I'm not sure why they're asking that. But no, that's within the reference range. So the answer is A and C. Number 5. A nurse is planning care for a client who has a PICC line, peripherally inserted central catheter. So it's a long line that we insert peripherally, and then we feather it up into the central circulation. Which of the following interventions should the nurse include? Okay, A, use a 10 ml syringe to flush the PICC line. That would be true. Okay, yeah. You wouldn't want to use a big syringe that can generate huge pressures that could blow the PICC line. So that would be true. Apply gentle force if resistance is met during injection. No, not usually. You don't try and overcome resistance by just pressing harder. There's usually a reason why there's resistance. So either the PICC line is blocked, or there's a clot in it, or it's kinked. So there's usually something wrong with it. Okay. C. Cleanse ports with alcohol for 15 seconds prior to use. Yes, that's a good idea, right? So you really want to reduce the chance of injecting any bacteria into the PICC line, so C would be appropriate. Maintain a transparent dressing over the insertion site. Yes, that's a good idea. We get to visualize the insertion site, right, for signs of infection at the insertion. E, flush with 10 mL of heparin before and after medication use. No, I don't think so. PICC lines are usually flushed with normal saline before and after the medications are given. Sometimes if a PICC line is not going to be used for a prolonged period of time, heparin can be instilled in the PICC line just to prevent any clotting, but typically it's normal saline that's used. Okay, so let's review the electricity of the heart. Okay, so the electricity of the heart is critical so that the heart will then take that electricity and turn it into a contraction by stimulating the myocardium, right? So we have automated pacemakers in our heart that are continually sending off a signal to the heart that's going to turn into a contraction of different parts of the heart. Okay, so let's talk about the normal physiology of the electricity of the heart. So that starts at the sinoatrial node. And when I call it a pacemaker, it's a natural pacemaker. It's influenced by the autonomic nervous system, where the sympathetic branch can increase the signal from the SA node and make the heart go faster, or with the parasympathetic branch, it can send a signal to the SA node to slow down the heart rate. Okay, so the SA node is an automated pacemaker. It continually depolarizes and repolarizes, and it sends out an electrical signal to the atrium. Okay, so let's see where the electricity goes. So first it starts at the SA node, and the electricity goes over both atria, right, through nerve fibers, and that's going to result in contraction of the atria. Okay, where does the electricity go next? So SA node, then over a whole bunch of nerve fibers in both atriums, and it's going to go to the AV node, the atrioventricular node. Okay, so that's a bundle of nerves in the AV node that's getting the electricity. And the AV node is the only electrical connection between the atria and the ventricles. Okay, there's no other normal way for electricity to get through to the ventricles except for the AV node. Once the electricity is in the AV node, It can send the electricity on downwards to uh, a large bundle of nerves called the bundle of His. Okay, the bundle of His is going to take the electricity and it's going to conduct it into the ventricles. It's going to branch into two separate branches, a right branch for the right ventricle, a left branch for the left ventricle, and then the nerves are going to get smaller and smaller, called Purkinje fibers, and they will cover the entire left and right ventricles with little nerves. And then finally those nerves attach to the myocardium, and they can depolarize the myocardium. Okay? So really understand the normal electrical uh, uh, pathway in the heart. SA node, and then over the atrium, AV node, and then down the bundle of His, and then the electricity branches into right and left bundles. Purkinje fibers are the tiny fibers in the myocardium. They're still nerve fibers though. And then finally, the myocardium itself, the muscle itself, okay? And this is all about causing contractions of the myocardium in different sites, right? So whether we're talking about the atrium, the atria contracting first, and then the ventricles contract to produce a systolic contraction. Okay. Okay, I'm not going to spend too much time on this slide. This is basically taking a health history for the cardiovascular exam. So common, symptoms that they may have, past medical history such as angina, family history such as previous heart attacks or atherosclerosis, medications that they take, so cardiac medications, their general nutrition, activity and exercise, and so on. Okay, so this is just a general health history. Okay, so when we're looking at chest pain, so someone comes in with the symptom of chest pain, that can be from an assortment of conditions, right? So let's look at a couple here. There's more than this, but let's just look at some here. So hiatus hernia or gastroesophageal reflux disease. Hiatus hernia just means that some of your stomach has herniated, is in your chest. That's all a hiatus hernia means. Gastroesophageal reflux disease means you're refluxing acid into your esophagus, and that can irritate your esophagus and cause typically burning chest pain. Okay. Bottom left, well, those are occluded or blocked coronary arteries causing anginal symptoms. Okay, and we obviously really want to catch this one when someone comes in with chest pain. So varying degrees of coronary artery occlusion will lead to either stable angina, unstable angina, an NSTEMI, or a STEMI. Okay, and patients often come in with heavy chest pain. It often radiates to the neck or to the jaw or to the shoulders. They'll often come in complaining that it's difficult to walk up a hill without getting chest pain. That's for stable angina, by the way. Unstable angina, they'll come in and say, usually I have stable angina, but now I'm getting it very frequently and all the time, and I'm just sitting there. I'm just resting. That's unstable angina. It means the plaque is occluding the coronary artery even more. It's not a heart attack, though. Their troponin is still normal. And then finally, NSTEMI and STEMI are myocardial infarctions, right? So again, the chest pain can be retrosternal chest pain in the front. It can radiate to the back. It can be in the upper stomach, the epigastrium. It can radiate down the left arm, or it can radiate down the right arm. Okay, so coronary artery occlusions will lead to chest pain because of lack of oxygen to the myocardium. Okay, What else can cause chest pain? Well, a pneumonia can definitely cause chest pain. Often they come in with coughing, fever, shortness of breath, plus they have some chest pain. Okay. A pulmonary embolus, where a clot has broken off from a deep vein thrombosis and traveled to the lungs, well, that's going to typically result in pleuritic chest pain. It hurts to take a deep breath. Often they're short of breath. They may have an associated swollen leg from the DVT. And sometimes they'll cough up blood. Okay. Pericarditis is inflammation of the pericardium, and this particular cause of chest pain is usually quite harmless. It's usually caused by a viral illness, and what it is because of the inflammation of the pericardium, they often come in with central chest pain, and they have a very specific symptom associated with that. When they lie down, the chest pain is worse. When they sit up and lean forward, the chest pain gets better. And it's typically pleuritic chest pain, meaning when I take a big breath, it hurts at the front part of my chest, the anterior chest. Okay. And the reason it hurts when they take a deep breath is when you take a deep breath, more blood comes back to the heart and it stretches the pericardium, which is inflamed, and they say, I have pleuritic chest pain. Or they say it hurts when I take a deep breath, okay? And it feels much better when I lean forward. Anxiety, panic, attack. Costochondritis is just irritation of the joints that attach the anterior ribs to your sternum. So someone who's been doing a lot of mechanical work or lifting, or they may have costochondritis. And when we palpate the ribs, they say, oh yeah, that's where it hurts. There's other causes too, though, right? A collapsed lung, a pneumothorax can cause chest pain, right? So these aren't the only causes. These are some of the common ones that we look for, okay? So definitely anyone who comes in with chest pain is going to get an ECG. We're going to get blood work, okay? Looking for an elevated troponin. In terms of if we think it's a pulmonary embolus, we may order a D-dimer, or we may order a CAT scan with dye, so a CTA of the chest, looking for a pulmonary embolus. Okay, so it just depends on what we think is happening in terms of the chest pain. Okay, so let's spend a bit of time on this slide. Cardiovascular assessment, so a physical exam, right? So most of the time we're thinking blood pressure, heart rate, maybe capillary refill, but let's just go through this a bit. So in terms of general appearance, are they awake, right? So if your blood pressure is low, you're not going to perfuse your brain very well, and you're going to have a reduced level of consciousness, right? So it's important from a cardiovascular point how the neurological system is doing, because it's relying on the blood to feed it, right? So people that have reduced cardiac output or low blood pressure, it's going to impact their level of consciousness and their mental status, okay? The neurovascular assessment of skin and extremities. So those 6 Ps are usually for either typically an occluded artery to a limb. Okay, so they don't really apply to, say, chest pain or a myocardial infarction. Let's say you have a blockage to your leg, an arterial blockage to your leg from, say, atherosclerosis, or an embolus traveled, say, from your heart due to atrial fibrillation, and it lodged into your femoral artery. Okay, so now your leg is blocked of blood. Okay, so it's what's called an ischemic leg. Well, if there's no blood supplied to your leg, you're going to have severe pain. because things are dying. Muscle, nerves, tissue is dying. There's going to be severe pain. The leg's going to be pale, right? Because of the lack of blood supply. It's going to be pulseless. Again, because of the blocked artery, we're not going to feel distal pulses, say at the ankle. Paresthesia is because the nerves are starting to die. So you're getting pins and needles. Poikilothermia is just a fancy term for temperature. So you're going to have a cold limb. And lastly, paralysis. The muscle has died and you now have paralysis. So that's where those 6 P's come into, okay? For an arterial blockage, typically of a limb. Blood pressure, very important. So we want to know the systolic and diastolic blood pressure, which is what we get with our blood pressure cuff. We want to know orthostatic pressures, meaning what's the blood pressure when the person is supine, lying down, and what's the blood pressure when we get them to sit up and then stand up and check it. And do they have orthostatic symptoms, meaning when they stand up, do they get dizzy, off balance, as if they're going to fall over? That can be an indication that their blood pressure is low. They have orthostatic low blood pressure, okay? And that can happen in dehydration. That can happen if someone's taking too much antihypertensives. That can happen if someone's bleeding from somewhere. They have orthostatic hypotension. Your mean arterial pressure is really just to get, it's just trying to get an overall average blood pressure. So how do we calculate mean arterial pressure? Well, most of the time you're actually in diastole, okay? So your heart contracts in systole and it relaxes slower. So 1/3 of the time you're in systole and about 2/3 of the time you're in diastole, okay, on average. So what we take is your systolic pressure and we add it to twice your diastolic pressure and we divide by 3. Okay, so it's taking your average pressure, your mean arterial pressure. Okay, the pulses, the peripheral pulses, we can determine the heart rate, we can determine the rhythm. Is it nice and regular? And we can tell the amplitude of the pulse, meaning is it a really weak, thready pulse, say in hypotension, or if someone's severely dehydrated, or is it a nice bounding pulse that we should normally feel, say at the wrist? Your JVP, jugular venous pulsations, so we put the head of the bed at around 30 degrees, and typically between 30 and 45 degrees, not straight up. And we're looking at the neck veins. And what we really want to see is there elevated JVP? So if there's an elevated JVP, it means that the blood isn't draining back to the heart very well. Why would that be the case? Well, what about congestive heart failure, where the right ventricle just can't accept all the blood that's coming back to it because it's also failing? What about a massive pulmonary embolus that's stuck in your pulmonary artery? Well, that's going to result in backup of blood into the right ventricle and into the venous system, causing an elevated JVP. Okay, so just think of an elevated JVP as something is blocking the regular flow of blood from the right ventricle to the pulmonary artery and then back to the left side of the heart. Okay, so let's just go some of these physical assessment signs or symptoms. So hemoptysis. So the more you hear about what causes all these things, the better you are off later on. Okay, so hemoptysis. Well, what can cause hemoptysis? Well, coughing up blood. Okay, so lung cancer, a pulmonary embolus, Sometimes you cough up a bit of blood, some frothy blood in pulmonary edema. Okay, so as soon as you see hemoptysis, you should think, okay, this could be a pulmonary embolus. I should think of maybe congestive heart failure with frothy pink looking sputum, or lung cancer. Okay, sometimes tuberculosis, you can cough up some blood. So hemoptysis is usually a concerning symptom. Okay. What about the coughing? Um, in terms of coughing, so many things can cause cough. So let's start at the top with a benign condition called acute bronchitis. Acute bronchitis is just a viral infection of the bronchial tubes. It typically resolves after 7 to 14 days, no matter what we do. Okay, because the vast majority of them are viral. COPD, chronic obstructive pulmonary disease. Well, they cough up. They cough a lot. They have a chronic cough. They have purulent sputum, and they're often short of breath. Okay. What else can cause coughing? Pneumonia can cause coughing. Okay. You're trying to hack up all the phlegm that's in the alveolar and in the lungs. Okay. In terms of cardiac, you can get some coughing with pulmonary edema, so congestive heart failure leading to pulmonary edema. Sometimes patients are coughing, but they usually have a whole bunch of other signs of the congestive heart failure. Crackles in the lung, so crepitations and crackles can be an indication of fluid in the lung. Okay, so if we were to listen to someone's lungs and on the left and the right side, they have crackles and crepitations, that can be an indication of congestive heart failure. If they have isolated crackles and crepitations in just one area of one lung, then we're going to think of something more focal, such as a pneumonia. Okay? Wheezing almost always comes from the bronchial tubes, right? Bronchoconstriction and excessive mucus. So that can happen in asthma, that can happen in COPD, and that can happen in, say, cystic fibrosis. And it can happen in an allergic reaction. So as part of anaphylaxis, you get wheezing because of bronchoconstriction. Okay? The hepatojugular reflex. Okay, well, what's that? So we sit someone up, just like in this image here, and we get them to turn to the left. So they're sitting up at around 30 to 45 degrees. We get them to look to the left, and we're looking at their jugular vein. Okay, and then we press on their liver in the right upper quadrant. And if the jugular vein just fills with blood when we press on the liver, that's an indication that the right side of the heart, the right ventricle, is not able to accept a lot of blood volume, and it's just filling back up in the jugular vein. Okay, so an elevated or a positive hepatojugular reflux is an indication of congestive heart failure, because the right ventricle cannot accept all the blood that you're trying to that you're pushing back into the heart by compressing the liver. Okay, so, and it just ends up in the jugular vein. Okay, I'm going to leave this slide to you, just abnormal, just heart murmurs. So S1 and S2 are normal. And really, these sounds are coming from the closure and opening of valves, right? And then you get into abnormal heart sounds, which typically are murmurs of some kind. So I'll let you listen to them. I'm going to tell you, in real life, it's very hard to distinguish any of these murmurs. It's so hard to distinguish mitral stenosis from, say, another type of valvular disease. Okay, so that's why we rely on an echocardiogram heavily. If we hear a murmur, we'll get an echocardiogram, which can look at the valves, and it can actually look at the flow of blood through the valves. Okay, so um, if we hear a murmur, yes, we can try and predict it's the murmur of aortic stenosis or it's the murmur of mitral regurgitation, but we need to confirm it, and that's with an echocardiogram. Friction rubs. So you can have a pericardial friction rub in the case of pericarditis because there's inflammation of the pericardium and the two layers of the pericardium are rubbing against each other. It almost sounds like sandpaper. So pericarditis can cause a friction rub. You can have a friction rub of your pleura. So if you have inflammation of your pleura from a condition called pleuritis, which is typically caused just by a virus, when you're breathing, when you're inhaling and exhaling, sometimes we can hear the friction rub of pleuritis. Okay, so that's all a friction rub means. Okay, so we're going to end up going through many of these, right? Some laboratory tests for the heart, electrocardiogram. There's going to be much more of that in the next module, but we'll talk a bit about it here. What's a Holter monitor? We'll go through that. Echocardiograms we've spoken briefly about. It's like an ultrasound of the heart, whether it's a transthoracic echo or a transesophageal echocardiogram. A stress test, where we put someone on a treadmill and get their heart rate really fast. That's an exercise stress test. Or we can do stress tests by injecting stimulants into someone, such as persantine or dipyridamole or adenosine, to get their heart rate fast, and they didn't have to do it on a treadmill, because many older patients can't do it on a treadmill. Okay, so we might call it an echo stress test, where we're going to inject them or put them on a treadmill and then lie them down and look at their heart when it's beating fast with an echocardiogram. We might call it a dobutamine stress test, where we injected them with dobutamine, we got their heart rate really fast, and now we're looking at the monitor to see if there's any changes on their electrocardiogram, their ECG. Okay. We'll spend some time talking about nuclear studies and what a CT angiogram is. And then we'll talk about heart catheterization. So getting a catheter to the right side of the heart, getting a catheter to the left side of the heart, and why. And lastly, electrophysiological studies. We'll discuss what those are as well. Okay, so cardiac labs. So the first lab test I think of is troponin, okay, because it's the most sensitive one we have to rule in or rule out a heart attack. Whether it's an NSTEMI or a STEMI, you're going to have troponin leaking out because the muscle of the myocardium has died a bit and it's leaked out troponin into the bloodstream. Okay, so sure, we can get a CBC and look at their hemoglobin to make sure that they're not anemic, and because patients with severe anemia, well, they can have chest pain. When you're severely anemic, it means that you're not able to carry a lot of oxygen in your hemoglobin since you're low on oxygen, and that could result in angina because you're not able to supply the heart with enough oxygen. Okay, but that's not specific. So a low hemoglobin doesn't tell you anything about the heart. Okay, potassium. We like to see the potassium's in the normal range. Why? Because a high potassium can cause very dangerous cardiac rhythms. And we'll talk about that in another module. Okay. So cardiac specific tests, troponin. Okay, definitely troponin. We want to see that a troponin is done when the person comes in with chest pain. Now, if the first one's negative and they've come in really early, say within an hour, that's not good enough. We need to do another troponin, usually 4 to 6 hours later, to confirm that that one's negative as well. Why? Because it can take 2 to 3 hours to even start to rise in the bloodstream. Okay, and troponin can last a very long time. It can last for days, up to about 10 days. Okay. Now, I mentioned this before, but cholesterol profile is not, it's not specific to the heart. It's just a risk factor for atherosclerosis. Okay. So remember your values though. Total cholesterol should be less than 200. LDL cholesterol less than 130. HDL cholesterol typically should be greater than 45 to 55. Okay, and triglycerides in general should be less than 140. BNP is a blood test that we can take, and if it's elevated, so we take it if we think someone might be in congestive heart failure, because BNP is released by the ventricles when they're distended. Okay, when they're filled with blood and they just can't pump all this blood out, which is heart failure, congestive heart failure. And they release BNP naturally, so it's a natriuretic peptide, and the ventricles are really smart. They send out this BNP, it goes to the kidneys, and it tells the kidneys, please get rid of some fluid. Okay, so it acts as a natural diuretic. Okay, so it'll be elevated in congestive heart failure. That's really all we typically use it for. Okay, so we order many more troponins. Every day we're ordering troponins for people coming in with chest pain. We're not always ordering BNPs, but as long as you know what it's for congestive heart failure, and it's elevated in congestive heart failure. Okay, so before we start this slide, let's do number 5. I forgot to need number 5 as part of the questions. So a nurse is completing the admission assessment of a client who will undergo peripheral bypass graft of the left leg. Which of the following findings would the nurse expect? So they haven't had the graft yet, and they're having it because they have a blocked artery to the leg. So we're going to think of signs of ischemia to the leg. So what happens if so the first answer, A, rubor of the affected leg when elevated. If we elevate a leg that already has a blocked artery, it's going to turn more pale, because now the poor artery has to try and get blood to the leg, but the leg's in the air, so there's gravity acting on it, so it's going to turn more pale. If we lower the leg on the side of the bed, then they're going to get rubor. They're going to get a red leg, what's called dependent rubor, because now we're allowing gravity to help the blood flow to the affected leg. So A is not correct. B, 3+ pulses to the left foot. No, those are fantastic pulses. So they shouldn't have 3+ pulses to the foot. They should have very or either absent pulses or a really weak pulse when we feel the artery in the foot. So B is wrong. C, thin peeling toenails of the left foot. Okay, that's a bit odd. Usually, if someone's not getting a good blood supply to their leg, the skin's going to be thin, the hair follicles are not going to be working, so there'll be less hair. They may have ulcers on their foot because they can't heal the ulcers. Sometimes they can get thickened toenails, but that's not a great sign. So I don't like C. I don't think it's the answer, but I just don't like it either. D, report of intermittent claudication in the affected leg. So intermittent claudication is where they go for a walk, so the leg needs more blood supply because they're using the muscles of the leg, and they get leg pain. And when they stop walking, the leg pain goes away. They start walking, the leg pain comes back. So because of the blocked artery in the leg. So you would expect that, right? So someone could definitely give a history of every time I go for a walk, my leg is painful, and when I stop, it gets better. So D would be the answer there. Now, we're not going to spend much time on this slide because you're going to get much more of it when we go over ECGs in another module, okay? So this is showing you an electrocardiogram. We're just going to keep it very simple on this slide because there's much more detail coming up. And you notice that on this image, we're getting actually not all of the different leads are here. We're missing 3 leads. But basically, the ECG is just showing you different views of the heart. Okay, so for example, AVL is one view of the heart. AVF, another position where we've put the electrode to see another view of the heart. And then V1 to V6 is just another view. Okay, so I wouldn't get into too much. Don't get confused by this slide. We're going to do much more of this in an upcoming module, including all the information on the left on this slide. Okay, so I would prefer that you remember the electricity of the heart that we spoke about at the beginning. The SA node generates a little impulse, goes to the atrium because of all the neurofibers on the atrium. And then the electricity goes from there to the AV node. The AV node sends the signal of electricity to the bundle of His. And then the left and right bundle branches. And then the Purkinje fibers, and then finally to the myocardium, where it causes a depolarization of the myocardium and results in a contraction, a systolic contraction. Okay? So we'll spend much more time on this in the next module. Okay, a Holter monitor. So a Holter monitor is a small device that we attach to a patient. So here on the right, you can see that there's electrodes attached to the patient, and the electrodes are going back to this device called the Holter monitor. And what's the Holter monitor useful for? Well, say someone comes in and they're complaining of palpitations. So they have the sensation of their heart skipping beats, or they have a feeling that the heart's not regularly beating, but we can't find it at the hospital in the emergency room. We can't find the cause. Everything seems fine. Well, we can put them on a Holter monitor to monitor the rhythm of their heart for 24, 48 hours. They return the device to the lab, and a computer will read the entire 24 to 48 hours of the rhythm of the heart. Okay, there's actually a button they can press on this for when they feel a symptom. They can press the button, so then the computer can look at that area to see if there was a missed beat, an extra beat, or to see the rhythm that occurred while they had the symptom. Okay. Now, some of these devices can be worn up to a month, and typically those are called loop monitors. So a loop monitor is really just a Holter monitor that's worn for a long time. That's all it is, right? So they get set up with this device. They go home. They do their regular activities. We don't tell them to rest. We don't tell them to do anything differently. They just go on with their day. Okay, then they return. Hopefully they've had some symptoms where they've pressed the button, and the computer can look at those events to see if anything has occurred with their rhythm. Okay, so really, for the most part, a Holter monitor is worn to detect any abnormal rhythms of the heart. The problem that patients often encounter wearing a Holter monitor is some people are really sensitive to the adhesive that holds the electrodes onto the chest. And they can get significant rashes, especially when people have to wear this device for weeks or a month. They start to get rashes where that glue is holding the electrode to the skin. Okay, so echocardiograms we've spoken about. So the two types is a transthoracic, where we put the probe on the chest, and we look at the heart from the anterior chest. Okay, and we can see the chambers, we can see the valves, we can see the contractility of the heart, we can see if there's any clots within any of the chambers. So it gives us lots of information about the chambers and the valves. Okay. A transesophageal echo will give us the same information. Typically, you need a bit of sedation and having not eaten the night before, so MPO. And the probe goes into your esophagus. And the reason for we do this one is it gives us such a close-up view of the heart. So we can really look at the valves up close. We can look for any clots, say in someone with atrial fibrillation, up close. Okay, so they're both just ultrasounds of the heart, just different ways of getting there. One's non-invasive, one's invasive. Okay. So here's an image of an exercise stress test. This person's on a treadmill. The treadmill is going to go faster and faster and faster to get his heart rate up. And with the electrodes on his chest, that's going to go to that screen. They'll be able to monitor for any arrhythmias or any changes on the ECG that might signify heart strain, or a heart that has potentially blocked coronary arteries can sometimes be seen on the monitor. Okay, so really what we're looking for with a stress test is when we get your heart rate up really fast, is the monitor showing changes on the ECG that are consistent with a coronary artery blockage or ischemia to the heart. Okay, so it can be done with a treadmill, and it can be done with drugs that we've spoken about, so pharmacological stress tests. Okay, we just want to get the heart rate up fast, and some people just can't walk the treadmill due to a number of conditions. So say someone with severe COPD, well, we're not going to ask them to do the treadmill test, but we can inject them with adenosine or dobutamine to still get their heart rate up. Okay, and typically for that one, your NPO typically around 3 or 4 hours before. Okay. Now, when do we stop the test? Well, we stop the test when the patient reaches their target heart rate. Okay, so and everybody has a predicted maximal heart rate. It's usually 220 minus your age. So if you're 50 years old, 220 minus 50 is 170. That would be your predicted maximal heart rate. Okay. We would also stop it if you develop chest pain, right? That's likely inguinal chest pain that you have, and we could cause a heart attack if we continue with the stress test while you have chest pain. So we're definitely going to stop it for chest pain. And if there's any concerning features on the EKG that may signify that the heart is under a lot of ischemic stress. So we can sometimes see that on the monitor, and that will be enough to stop the treadmill test or the pharmacological stress test, and to say, okay, that's enough, we better not go any further. We likely need to do an angiogram to look at your coronary arteries. Okay. Okay, so a nuclear stress test, well, we just inject a pharmacological agent to get your heart rate up, and we're also injecting some kind of a nuclear agent such as thallium to go to the heart so we can see images of the heart. Okay, so if we look at the right here, at rest, you can see the bluish orange area. Well, that's showing where the heart is receiving proper blood supply. Now, the person is under stress, so their heart rate's going faster, it's working harder, it needs more oxygen, and it's showing that no, it's not getting enough oxygen to that area. Okay, so This is a pharmacological test where they inject dye and then they get your heart rate up. Okay, it's still considered a stress test. It's a nuclear stress test. Okay, and again, we'll stop it for the same reasons. If the maximum heart rate is reached, well, we're not going to go any faster with the stimulant. If there's any chest pain or if there's any ECG changes. Okay, so on this test, they can actually see the monitor with the ECG on it, and they can also see these images that we're looking at on this slide to see what's happening when the heart rate goes fast and the heart is working faster or working harder. What's happening? Is it getting enough oxygen to the myocardium? Okay, and in this case, it's not. Okay, the image under stress is showing you that it's not getting enough blood supply while the heart is going fast. Okay. Okay, so let's just look at some other tests. So a CT angiogram. Remember, we spoke about an angiogram when we spoke about PCI. This is a CT angiogram, and we'll come to it. A right heart catheterization and a left heart catheterization. So these are all just diagnostic tests looking for heart disease. Okay, so just like the Holter monitor was looking for arrhythmias in someone with dizziness or feeling palpitations in their chest, and the stress test was looking for signs of ischemia on the monitor while the person's on the treadmill. These are just other tests to look at the heart and for any heart disease. Okay, so here's a CT angiogram. Okay, so you get a lovely image. You can see the coronary arteries going down. So it's much less invasive than a normal angiogram because with a typical angiogram, you have to go into an artery. Okay, so it's your wrist or your femoral artery, and then thread up the catheter to the heart, and then put dye in to the coronary arteries, and then see the anatomy of the coronary arteries to see if there's any blockages. A CT angiogram, okay, you get some dye put in, and they wait for the dye to get up to the heart, and then they do a CAT scan. The problem with it, so there's still radiation with this, but the problem with it is when you see something, there's nothing you can do. You still have to go on to a PCI, a percutaneous coronary intervention. So they're not overly popular because of that reason. So I have the test, I see something wrong, but I still have to go on to have the other test and procedure, which will be the PCI. Okay, so say we want to find out information about the right side of the heart. So we want really detailed information because we think that there's something wrong with the right side of the heart, or that there's high pressures in the right side of the heart for some reason. So we can do a right heart catheterization. So how do we get to the right heart? Through a vein. Okay. So we insert the catheter into the vein, and that catheter has the ability to measure pressures and measure oxygen saturations. So we can get the catheter into the inferior vena cava or the superior vena cava by accessing the central circulation, and then we can get it into the right atrium, right ventricle, and pulmonary artery. And you can see the image on the left there that the catheter is coming from the jugular vein, and it's threaded down, and on the way down it's taking pressures. Okay, and look at the pressures at the right side of the heart. They're low, right? It's the venous side. So the right atrium, very low, right? 2 to 8 millimeters of mercury. Right ventricle, when it pumps, 15 to 30. Compare that to the left ventricle. 100 to 140 millimeters of mercury to overcome the pressure in the aorta. So very different pressures on the right side of the heart, much, much lower, okay? So in actual fact, the right side of the heart doesn't have to work as much as the left side of the heart, okay? It's good to know the range of those pressures, by the way. So the blood coming back into the right atrium, it's generating a pressure between 2 and 8, pretty low. The right ventricle, when it pumps, 15 to 30, and then relaxes, 2 to 8. The pulmonary artery, typically 15 to 30 during systole, and 4 to 12 during diastole. Just good to know those pressures, right? So that's what a right heart catheterization is used for, and it can be helpful to diagnose pulmonary artery hypertension, right? So if you have really high pressures in your pulmonary artery, there's usually a reason for that. So what can cause pulmonary artery hypertension? Well, there's something wrong with the lungs, such as COPD, that are destroying the capillary beds, and so the blood can't flow through. That's going to lead to pulmonary artery hypertension. Left heart failure, where the left ventricle is not able to pump blood out, so it's backing up into the lungs, and it's backing up to the pulmonary artery, causing high pressures, okay? So it can give a lot of information about what's happening with the pressures and the oxygen on the right side of the heart. Now, this catheter can be left in if the patient is very ill, and monitoring of the right venous pressure. So the venous pressure is, of course, on the right side of the heart, the inferior vena cava and the superior vena cava, and it can be left in for CVP monitoring, okay? So central venous pressure monitoring. Okay, so just an overview of hemodynamic monitoring. So central venous pressure we've spoken about. They go into one of the central lines, such as the jugular or the subclavian vein. They thread a catheter in and they obtain pressures, right? So central venous pressure, so say in the vena cava, 2 to 6. Very low, right? Very low pressures. Pulmonary artery, so they thread another part of the distal lumen into the pulmonary artery, and they can get pulmonary wedge pressures, which just means they've threaded it further into the pulmonary artery, and they get a pressure as far into the pulmonary artery as possible. They can get pressures in the right ventricle, and it really just gives a good idea of how the pumping, how much pressure is being generated by the pumping of the right ventricle. What's the oxygenation of the blood returning to the right side of the heart? Now, an arterial line that's mentioned at the bottom left, that's the arterial side. So don't confuse them. We've been talking about right-sided catheterization. An arterial line goes into an artery such as your radial artery or your femoral artery, and that obtains minute-to-minute blood pressure readings for someone who is extremely ill, okay? In fact, hemodynamic monitoring on the right side of the heart that we're seeing here is for people that are very ill, okay? We don't do this otherwise, okay, because it's invasive. Okay, so here's an image showing left heart catheterization, okay? So now that's going to have to be done through an artery to get to the left side of the heart. So they thread up a catheter, and they thread it all the way up the aorta to the aortic arch, and then into the left ventricle. And they can get information about the aortic valve, the mitral valve, the left ventricle, so they can measure pressures there, how much pressure the left ventricle is generating. They can look at the coronary arteries to see if they're open or blocked, and they can look at all the branches of the aortic arch, which are the branches that are going to the brain, right? So subclavian artery, um, uh, carotid artery, all those they can assess with the left heart catheterization. Okay, so these are just some comparisons between the right heart cath and the left heart cath. One enters a vein, and the left heart cath enters an artery. Okay, one wants to get to the right side of the heart, one wants to get to the left side of the heart, and to obtain different information from each side of the heart. Okay. Now this image is just showing you where to apply pressure um, when someone's had a catheterization, especially into an artery for sure, right? So it's not necessarily where the puncture of the skin is, because that's not where the puncture of the artery is, right? It's proximal to where it went through the skin. So the pressure applied needs to be over the arterial puncture, not where it punctured the skin. Okay, so catheterization complications. Remember, to access the left side of the heart, you can use the femoral artery or the radial artery can be used to get a catheterization up to the aorta, and then finally into the left side of the heart. Okay. So, what are some complications? We've spoken about these. So, retroperitoneal bleeding would occur only if the femoral artery was used. Okay. Myocardial ischemia. So, that's with a left heart catheterization, where we threaded the catheter up, and something occurred with a complication occurred with the coronary arteries, and one of them became blocked. Okay. Bleeding at the site of insertion, sure, because you're puncturing an artery if it's a left heart catheterization. Dysrhythmias, anytime you put a probe or a catheter into either side of the heart and you touch the wall of the inner chambers of the heart, you could trigger arrhythmias, so irregular beating of the heart. Okay. Venous spasm, sure, you could cause a vein to go into spasm with a right heart catheterization. Infection is always a risk whenever you open or puncture the skin. Perforation, you could perforate an artery, which is bad news, right? Because arteries are under high pressure. You could perforate a coronary artery. You could perforate as you're threading the catheter up the aorta. Something could be accidentally perforated and cause a lot of bleeding. Okay, so those are things to think about. The device on the left is showing you a pressure device that's being applied after a femoral artery, so a left heart catheterization, right? And it's just holding the pressure there to stop the formation of a hematoma. Or even worse, an outer arterial bleed. So you really want to put pressure there to allow that artery to heal after it's been punctured. Okay, so I'm going to leave this. Slide. I think it's pretty clear. Just a pre-procedure and post-procedure for different approaches. Remember, when you're doing a femoral approach, and you've gone through the femoral artery, well, there's going to be a period of bed rest. There's going to be a period of leaving your legs straight to allow that artery to heal. So you don't want someone moving around just after they've had their their femoral artery accessed with the catheter, right? But I'll leave the rest for you on this slide, and we'll go on. Okay, so electrophysiology studies, we'll talk about these in the next module too, but what are we doing? Well, this is typically for a patient that has some kind of abnormal rhythm, right? And there's there are many abnormal rhythms that occur with the heart. And sometimes we send people to the EPS lab to find out which rhythm are they getting. Or sometimes we'll find some kind of odd rhythm at the hospital, and we'll send them to the EPS lab to really determine the extent of the arrhythmia. Okay, so arrhythmia, dysrhythmia, they mean the same thing, some kind of abnormal rhythm. Okay, so this lab is used to diagnose and map out in the nerves of the heart where the abnormal rhythm is coming from. Okay, so it's actually a pretty complicated process. So people that work in the EPS lab know all about the nerves of the heart in great detail. Okay, now if they find the cause of the arrhythmia and they can see that it's some kind of abnormal bundle of nerves, they can ablate it, they can burn it, right? So not only can they diagnose the arrhythmias, especially some of the deadly arrhythmias, but they can actually do procedures so that the arrhythmias don't come back, such as ablation. Okay. Okay, so let's talk about some issues related to coronary artery disease. So when we say coronary artery disease, we mean atherosclerosis and the buildup of plaques within one or more coronary arteries. And as plaques get bigger and bigger and bigger within the lumen of the coronary arteries, they restrict blood flow. And when they restrict blood flow in the coronary arteries, the patient gets symptoms, right? Because the coronary arteries are responsible for feeding the heart with oxygen and glucose. So, so we want to know if there's significant blockages of the coronary arteries that are causing this person's chest pain or shortness of breath, right? So, so coronary atherosclerosis is by far the most common problem that we're going to be talking about in the coronary arteries. So, plaque formation that gradually builds and builds over the years until it occludes or begins to occlude the coronary artery. And as it occludes the coronary artery and reduces blood flow, a patient may have stable angina. So stable angina is, I don't have any symptoms at rest, but when I go for a walk up a hill, I get chest pain. Why? Because walking up that hill, my heart needed more blood flow in the coronary arteries to provide more oxygen and glucose, and it was unable to get it because of a coronary artery plaque or occlusion. Okay, but it's stable, so the plaque's not getting bigger, it's just staying the same size, and usually the patient has predictable symptoms at a certain level of exercise. In fact, some people come in and say, when I walk up a certain hill at home, I get chest pain. And when I sit down, it goes away within a minute or two. Okay, so that's stable angina. Very predictable, and it's from a fixed occlusion in a coronary artery. It's not completely blocked. It might only be 50 or 60% blocked. And the symptoms occur with exertion. So we call it exertional angina or stable angina. Okay, everything after stable angina, we're going to put under the umbrella acute coronary syndrome, ACS. Okay, because they're more critical. Okay, they're on their way to causing much more damage. So unstable angina is where the plaque, say the person had stable angina for a few years and everything was fine. They'd walk up a hill, they'd stop, they'd take their nitroglycerin after sitting down, and it would disappear, and they'd continue on until it happened again. Very predictable. Unstable angina is where the plaque is blocking much more of the coronary artery, okay? And so it might be 90% occluded or 95% occluded. So now their angina has become completely unpredictable. They have pain at rest. They have chest pain sitting at the dinner table. They have chest pain while sleeping. So the frequency of the chest pain has increased and it's become unpredictable. And they have rest pain as well. Okay, so it's not that stable angina anymore. It's become chest pain throughout the day, unpredictable. And what it's telling us is, ooh, that coronary artery is becoming critically occluded. How do we know it's unstable angina and not a heart attack? Troponin. Unstable angina will have a negative troponin in the blood. There's been no myocardial infarction. Okay, it's still very important, and it still needs hospitalization. It's just that there hasn't been a heart attack yet. Okay, sometimes we'll see it on the ECG. We often get it from the patient's history, and the serum troponin is negative. Okay, myocardial infarction. So myocardial infarction, by definition, by what it's saying is there's been a heart attack. There's been an infarction, which is myocardial cell death. And there's going to be release of troponin into the blood. So in a myocardial infarct, you are going to have elevated troponin. There's two types. There's an N-STEMI, which is a non-ST elevation MI. And so now we're talking about how it looks on an ECG. So there's heart attacks that don't have what's called ST elevation, and we'll call them an N-STEMI because they have a positive troponin, and a STEMI. So ST elevation MI, on an ECG, we can see a STEMI because the ST segment is elevated and they have a positive troponin. Okay? We'll get to those terms in much more detail in the following module where we look at ECGs. Okay, so an N-STEMI is a critical occlusion of a coronary artery where there's just not enough blood flow getting through, and part of the myocardium is starting to die. Okay, and it's releasing troponin into the bloodstream. They've had a heart attack. An N-STEMI is usually, so where does the myocardium start to die when you have an N-STEMI? It's the muscle closest to the chambers, what's called the subendocardial muscle. Okay. Whereas in a STEMI, we call it a transmural MI. The entire thickness of the muscle of the heart has been affected in a STEMI, whereas in an N-STEMI, it's usually just the muscle that's closest to the chamber where the blood is being pumped. Okay, so a subendocardial MI. Okay, a STEMI is complete occlusion of a coronary artery, no blood flow at all, and the entire thickness of that part of the myocardium is dying. Okay, so part of it is already dead. That's why it's an infarction. And if not treated, more of it will continue to die. That's why it's so important to open up the artery, the coronary artery, in a STEMI. Okay, to get that blood flowing to the area that's dying. Okay, so let's look at the coronary arteries. So you have to go up to the aorta, or just follow back these coronary arteries, and you have a right coronary artery that's going to wrap around the right ventricle, and you have a left coronary artery. Both of them are going to come off of the aorta. And what's their purpose? To feed the heart with oxygen and nutrients, right? Every organ in your body needs arteries to feed it with nutrients and oxygen. Okay, so the left main coronary artery, or the left coronary artery, branches off into a large, well, there's a large branch that goes down the front of the heart called the left anterior descending artery. And the rest of it wraps around the left side of the heart called the circumflex artery. The left anterior descending artery is a pretty important artery because it feeds the left ventricle, the major pumping of the heart. And when that gets blocked, it's a pretty big deal. Some people don't survive a complete occlusion of the left anterior descending artery or the left coronary artery for that matter, because it's feeding the left ventricle. And if the left ventricle dies, well, the pumping is not good. Okay, so that's the anatomy. So left and right coronary artery. The left coronary artery becomes the left anterior descending, and the other branch of the left coronary becomes the circumflex that wraps around the left part of the heart, and the right coronary artery that feeds the right side of the heart, and also it wraps around the bottom of the right side of the heart. Okay, so let's talk about coronary artery atherosclerosis. Remember, atherosclerosis is an arterial disease that happens all over the arteries in your body. So you could have cerebral artery atherosclerosis, renal artery atherosclerosis. You can have peripheral vascular atherosclerosis to the arteries to your legs or to your arms. So it's not usually isolated just to the coronary arteries. I know that's what we're talking about today, but remember it's an arterial disease. Okay, so it's typically not just isolated to the heart. Okay, so let's look at the image on the right. Okay, so there's a healthy artery at the top. The inner layer is the endothelium. It's like a saran wrap. It's a very thin lining that allows the blood to flow, but not stick to it, right? So it's made so that the blood recognizes it as normal and it doesn't cause clots or plaques or anything on it. And over time, there's some kind of an injury to the endothelium. That could be inflammation within the artery. That could be toxins, cigarette smoking, hypertension. Some kind of injury that has occurred over years is now injuring the endothelial lining. And you're starting to form plaques. And usually at the beginning, the plaques are minimal. They're what are called fatty streaks. Okay, and fatty streaks can be seen in teenagers in early 20s. Okay, depending on whether they have hypertension, diabetes, their diet, exercise level. Okay, any of those things will impact the arteries. And after minimal streaks, you start to get small plaque formation. And what's in the plaques? Well, there's usually inflammatory cells and lipids and fats and cholesterol that are depositing in the arterial wall. Okay. Now, there's still an endothelial lining. Okay, so if you look at the third image, there's still an endothelial lining where the blood is flowing across. And as the plaque gets bigger, so image number 4, filled with inflammatory cells and fat and lipids and cholesterol, it's starting to block more and more of the lumen of the artery. And in this case, we're talking about the coronary artery. And it's forming a plaque that's going into the lumen of the artery. So it might be just 10% blocking the artery, or 20%, or 30%, or 80%, okay? So it's forming what's called a fibrous plaque. Now, trouble starts when that plaque ruptures, and all the stuff that was inside the plaque now squeezes out. And what happens is the blood now recognizes this stuff as foreign and attacks it, and it forms a clot on it. So not only do you have a clot rupture, or sorry, a plaque rupture, but you have clotting happening on the plaque rupture by uh, the body's natural clotting ability. Okay, so someone may go on for years and have plaques, and they may have a stable plaque, which will form angina, stable angina, right? Predictable angina. And then one day that plaque ruptures. So it suddenly ruptures one day, fills the coronary artery with with the stuff that was in this plaque, and suddenly the blood is clotting on top of it because it wants to stop it. It sees it as foreign, and you have suddenly coronary artery occlusion, and that's what leads to unstable angina, an NSTEMI or a STEMI, or if it's complete occlusion and the heart just stops beating, well, cardiac arrest. And cardiac arrest means no pumping of the heart. Okay. So again, the cholesterol is really just a long-term risk factor. I know it's listed there. It's just a long-term risk factor. So high LDLs and low HDLs are just a risk factor for this process to occur. Just like smoking is a risk factor. Just like hypertension is a risk factor. And diabetes and family history. They're all just risk factors. So don't see cholesterol as, oh, this is the worst risk factor. No, smoking, family history, diabetes, they're all risk factors for this process to be accelerated. Okay. Okay, so here's the risk factors. I didn't need to mention them on the slide before. So smoking, why does that cause coronary disease? The toxins in the bloodstream damaging the arteries and accelerating plaque formation, just like the rest of these. Hypertension, same thing, damages the arteries. Hyperlipidemia, which is high cholesterol levels, same thing. Diabetes damages the blood vessels. Okay, but the high sugar content in the blood is damaging the vessels and leading to atherosclerosis, type 1 or type 2 diabetes. Obesity, obesity often leads to hypertension and hyperlipidemia and diabetes, so it's a risk factor in itself. Family history and your genetics is definitely a risk factor, okay? Your age, so the older we get, the more chance that we've developed more coronary artery disease. Race can be an issue, and inactivity. Okay, so a sedentary lifestyle where the coronary arteries don't receive lots of blood flow during exercise, that can lead to atherosclerosis in many of the arterial beds, not just the coronary arteries, but others as well. Okay, so really the prevention is change the risk factor, change the modifiable risk factors, right? Smoking is modifiable, hypertension is treatable, hyperlipidemia is treatable, diabetes is treatable, obesity is treatable, inactivity is treatable. So many of these are modifiable, some of them aren't. Family history, age, race, not modifiable, right? Okay, so let's move on here. Okay, so angina pectoris or angina is episodes of chest pain, or some people describe it as chest pressure. And what is it? It's inadequate oxygen supply, but increased demand. So I go for a walk, I'm going up a hill, my heart's beating faster and harder, I need more oxygen, but the coronary artery is somewhat blocked, it can't provide more flow. So the demand from the heart for more blood is there, but the supply can't be increased, what do I get? Chest pain, right? So ischemic chest pain. Okay, and then I stop, I feel better. So the demand has gone back down to normal and the supply has remained the same. Okay, so two types, stable angina is totally predictable. It's totally consistent with a certain amount of exertion, and then it's relieved by sitting down and resting, and even taking nitroglycerin. Okay, some people don't take nitroglycerin; they just sit down and rest. But many people have nitroglycerin. They can put a tablet under their tongue. It'll also relieve the pain of angina. Why does it relieve the pain of angina? Well, it can vasodilate the coronary arteries and help a bit more blood flow to get through. And it also reduces blood pressure because it vasodilates the arteries. And it also vasodilates the veins, so it reduces more blood from returning to the heart. So it's basically just taking the workload off the heart. Less blood returning, lower blood pressure that the heart has to pump against, and on top of that, it vasodilates the coronary arteries. Okay? So what's it from? Atherosclerosis in the coronary artery. Is it a critical lesion? No. It's a lesion that's big enough that when you go and exert yourself, you get chest pain and then goes away. Some people describe it as indigestion. Some people get it in the epigastric area of their abdomen. What do? Well, we've obtained the patient history. We're going to get a 12-lead ECG. We're going to do labs, especially for troponin. And also, we'll get a CBC because we want to make sure that the patient's not anemic. Remember, if you're anemic, you're not carrying enough oxygen to the heart, and that can give you angina. Rarely, but it can happen. And then with angina, if it's new onset angina, we may set them up for an exercise stress test or a nuclear stress test. Or if we think it's really severe angina and the patient has symptoms at very little activity, or if it's unstable angina, we're going to set them up for a cardiac catheterization to look at their coronary arteries. Okay, so they may need a percutaneous coronary intervention where they look at the coronary arteries and then they have the ability to either perform angioplasty to open up the blockage and put a stent across it. Okay. Okay, so let's talk about acute coronary syndrome. So under that umbrella, unstable angina, and the two types of myocardial infarctions, NSTEMI and STEMI. How do we differentiate between an NSTEMI and a STEMI? On the ECG. They both release troponin into the bloodstream. So without an ECG, there is no way of knowing an NSTEMI from a STEMI because that's what it's referring to, right? The ECG. So let's look at the image here on the right. So at the top, you got some plaque buildup. And that could just be stable angina. Okay, there's enough blood flow to get through. Everything's fine until you go and exert yourself. And then you get some chest pain that resolves with rest and maybe some nitroglycerin. Okay, the middle one is still showing angina, but let's just say that that plaque is enough to cause, say the plaque has built up and the plaque is now rupturing. So it's become what's called a complex plaque. So a person was going along just fine with stable angina, and then one day the plaque cracked open in the coronary artery, and all that fatty, cholesterol-laden tissue leaked out of the plaque and is exposed to the blood. And the blood says, whoa, I don't want this here. I'm going to clot on you. And enough of the coronary artery is blocked, so let's say 90 or 95%, but there's still enough blood going through the coronary artery that there's no heart attack yet. But what are the symptoms the person has? Increased frequency of chest pain, rest chest pain, nighttime chest pain. So it's not exertional at all. It's all over the place. That's unstable angina. How do we know? Well, from the symptoms the patient's telling us, sometimes the ECG will show some changes and negative troponin. Okay. What about a heart attack? Well, I spoke about the two types, an end-STEMI, meaning yes, there's been cell death, there's been myocardial death, yes, there's troponin leaking into the bloodstream, but we're not seeing an ST elevation on the ECG. That's an end-STEMI. There's still been a heart attack. It's a critical occlusion of a coronary artery. They definitely need to come into hospital, just like unstable angina needs to come into hospital. STEMI, complete occlusion, right? No blood flow. It's going to be a full thickness myocardial infarction from the outer part of the myocardium to the inner part, whereas an end-STEMI is typically just the inner part of the myocardium. Okay. Both have positive troponins. You're going to see that we treat them differently, though. Okay, so acute coronary syndrome. So if someone comes to the hospital and has symptoms of escalating chest pain, I have more frequent chest pain, I have shortness of breath, I'm sweaty sometimes, I have radiation to my left arm, I got some epigastric pain. There's no way of knowing, is it unstable angina? Is it an end-STEMI? Is it a STEMI? There's no way. We need to do tests, right? We need to do an ECG, and we need to do serum troponins. Okay, so so any of the three in acute coronary syndrome can lead to chest pain or chest pressure, left arm pain, left jaw pain, shortness of breath, indigestion, and then it's up to us to distinguish. Okay, is this unstable angina? Meaning, okay, there's definitely a critical occlusion in the coronary artery, but there's no release of troponin. There's been no heart attack. Okay, let's do an ECG and a troponin. Okay, is this an end-STEMI? Let's do an ECG and troponin and figure it out. The troponin is going to be positive. The ECG is going to show changes of an end-STEMI. We'll talk about that next module. Let's see if it's a STEMI. Well, there's going to be ST elevation on the ECG, and there's going to be a positive troponin in the bloodstream. So these things we often have to figure out at the hospital. Okay, so let's just have a little mini case here. So a 75-year-old comes to the triage at the emergency room, sits down, and she says, I've had chest pain today. Okay, and I have a bit of shortness of breath, and I was a bit weak and sweaty this morning. Okay. So she has her vitals taken, and she looks pretty stable there, but we take her right back, right? We don't put her in the waiting room. We take her back, and the first thing we're going to do is a 12-lead ECG. Okay? Now, if there's lots of staff, we're definitely going to put an IV in as well. We may even give her some oxygen if her O2 sat is low. If we think it's angina or one of the other more concerning heart conditions like unstable angina or an end-STEMI or STEMI, we're going to give her aspirin. Okay? We might even give her a spray of nitroglycerin if she still has chest pain. Okay, so we get the 12-lead ECG and we've taken some blood work. Okay? The first thing that we want to do is we want to look at the ECG to see if there's any changes that can signify a heart attack, in particular a STEMI, because a STEMI is emergent. We need to open up that coronary artery because it's completely blocked. So if we're in a small center that's hours away from the ability to get into the cath lab and perform a PCI, we're going to give them a fibrinolytic such as TPA to try and open up that coronary artery. Okay. If it's a STEMI and you're in downtown Salt Lake City, you're going to go directly to the cath lab because there's enough time for the ambulance to get you to the cath lab within that 120 minutes, okay, which is usually the cutoff. So if you can get to a cath lab in less than 120 minutes, and they can have a needle and a catheter going into your coronary arteries, then that's the option. Okay. So on the ECG, what are some changes that signify damage? Now, don't worry about these too much. We're going to spend much more time on them on the upcoming module. Inverted T waves. Okay. You can just take it for what it's worth. We're going to talk about it later. The ST segment can be elevated. Well, that would be a STEMI. The ST segment of the ECG can be depressed. That can be in an NSTEMI. Hypertrophic T waves, these huge T waves, that can signify a STEMI. Okay. I want to say that all of these things are going to be explained in the next module. Don't worry about it. Okay. We'll do a chest X-ray, looking at the lungs to see if there's any fluid in the lungs. Is there any cardiomegaly? Is there an enlarged heart? And of course the labs, troponin, right? So all of these are helping us figure out, okay, what's going on here? Do we think it's unstable angina? Do we think it's an NSTEMI? Or do we think it's a STEMI? Okay, and a lot of it is based on the patient history first, then the 12-lead ECG, and then, of course, the serum troponins. So this is the diagnostics, but remember, at the same time, we're also providing therapeutics. We're giving them oxygen if needed. We're giving them a nitro tablet under their tongue if needed. We're inserting an IV line. We're putting them on a cardiac monitor. We're doing frequent vitals. So all of those things are happening at the same time. Okay, so what's the overall aim of someone coming in who is coming in with a heart attack, a myocardial infarction? Okay, so they've got either a critically occluded coronary artery, such as in an NSTEMI, or they have a completely occluded coronary artery, such as in a STEMI. So the overlying goal is to get that artery open, right? We have to get that artery open to begin blood flow down the artery again. Okay, so you're going to hear a lot about blood thinners because we use blood thinners to try and get blood flowing through that occluded artery. Okay, you're going to hear a lot about other medications as well. We're going to talk about an assortment of medications that we can use in NSTEMI, and what do we do about a STEMI. Okay, so just some terms first. Ischemia. Ischemia is just reduced blood flow in a coronary artery that's not meeting the demands of the heart, and that causes ischemic chest pain. Okay, nothing's died yet, it's just ischemic cells, and that's causing the chest pain and shortness of breath and whatever other symptoms, jaw pain, shoulder pain, all the other symptoms. So no cells have died yet, so we could use that for angina or unstable angina. Infarction, there's been cell death. Okay, so the cells, some of the myocardial cells have died because of reduced blood flow, and there's been a myocardial infarction. Okay, so we're going to talk about the medical management of how we're going to minimize myocardial damage because of this blocked coronary artery. We want to minimize the amount of muscle that dies and preserve the myocardial function, the pumping of the heart. We want to prevent complications of the myocardial infarction, such as heart failure, where so much of the muscle has died that the person ends up with congestive heart failure, or they can get dangerous rhythms from a heart attack because it's irritating the nerves in the heart, and the nerves go into these wild rhythms. Okay, we need to decide where are we going to put this patient. Do they need to go right to the cath lab, or do they need to go to telemetry or the ICU? Okay. Cardiac rehab is afterwards, right? So education about how to reduce their risk factors and cardiac conditioning, physical conditioning, to try and prevent future events. Okay. So on the right is the guidelines for someone who say the ambulance does an ECG while bringing someone in, and they see on the ECG that there's an acute myocardial infarction. Okay, so usually this is going to be a STEMI because STEMIs are really clear on the ECG. So they rapidly transport the patient to the hospital. We try to do an ECG within 10 minutes, and that's usually the case within 10 minutes that we do a 12-lead ECG. And what are we looking for? We're looking for signs of ischemia. What's ischemia? Well, that could be unstable angina, and we're looking for signs of an NSTEMI or a STEMI. Okay, and depending on what we see on the ECG is going to really determine what's going to happen to the patient. Okay, as we'll talk about in a minute. Okay, so we look at the electrocardiogram. We see if there's signs of unstable angina or NSTEMI or a STEMI. We take blood work, especially troponin. Troponin is super sensitive for heart attacks. So we'd look at that troponin to see if it's elevated. Okay, if it's not elevated, that doesn't mean that the patient's out of the woods in terms of having a heart attack, because if they came in soon, troponin can take 2 to 3 hours to be elevated. So we need to keep them and do repeat ECGs and repeat troponins. Okay. What medical interventions? Well, they might need some oxygen if their O2 sat is less than 95%. We might give them some nitroglycerin under the tongue to try and vasodilate the coronary arteries and reduce blood pressure. We might give them some kind of opioid medication as a painkiller. That's not a priority, but we might, if they're having severe pain, at some point give them some opioids, so fentanyl or morphine. Aspirin. Aspirin is one of the first things we give patients, okay, as they're coming through the door with a heart attack. Beta blockers, why? They slow down the heart, and that allows the heart to rest. Okay, so in myocardial infarctions, we'll sometimes use beta blockers. Angiotensin converting enzyme inhibitors we'll use. Why? They reduce blood pressure. Okay, but let's just talk about the ones that we use first. Aspirin, definitely number one. Sure, we can give nitroglycerin to try and help with their chest pain and vasodilate the coronary arteries and also reduce systolic blood pressure or systemic blood pressure. But then we're going to go right to the anticoagulants, okay, to try and see if we can open up this coronary artery with unstable angina or an NSTEMI. Okay, so we might use heparin, or we may give them what's called clopidogrel, which is a platelet inhibitor. So they've already had aspirin, and they might get clopidogrel, which is another platelet inhibitor on top of the aspirin. And on top of that, they may get a heparin type medication, or enoxaparin, which is similar to heparin. Okay. Sure, we can give a statin to lower cholesterol, but that's definitely not one of the first ones we're going to give. We're going to give aspirin, blood thinners, nitroglycerin, and then we're going to start introducing beta blockers and angiotensin converting enzyme inhibitors. Okay. So let's see if we can clarify this on the upcoming slides. Okay, so I'm going to talk about some medications that we can use in angina and that we can use in myocardial infarctions. Okay, now I don't want you to get the impression that these are the sequence of drugs that we give when someone comes in with a heart attack. Okay, because that's not the case. And I can try and clarify that a bit later, but that's not the case, okay? So remember, what's the overriding um, goal that we want to do in someone who has a critically occluded coronary artery, say in unstable angina or um, a heart attack, an NSTEMI or a STEMI? We want to open up that artery, the coronary artery, right? So you're going to see that antiplatelet drugs and anticoagulants are going to be some of the first ones that we're going to give, okay? Sure, the other ones are important, beta blockers, maybe some nitroglycerin, but not to the same extent as the antiplatelets and the anticoagulants. Okay, so let's have a little case here, and then maybe some of the medications will make sense. So the first case is someone comes in and they say, every time I walk up this hill, I get some chest pain, and when I stop, it goes away, and it predictably happens every day. Okay, that's stable angina. What do they need? So they have a plaque in their coronary artery. It's not critical, and when they go up a hill, the heart needs more oxygen, and it's not getting it because of the coronary occlusion. So we can put that patient on aspirin. We could put that patient on a beta blocker to rest the heart, so the heart rate doesn't go as fast when he goes up that hill, and he'll get less angina. And we could give him a nitroglycerin so that he can put it under his tongue when he goes up that hill and he gets chest pain. He can take a nitroglycerin tablet. Okay? And then we're going to set him up for some tests, like an exercise stress test, maybe a nuclear stress test, and investigate his angina. Okay, let's go on a bit more. Somebody comes in with unstable angina or a myocardial infarction. Okay, acute coronary syndrome is the umbrella. What can we do for them? Well, typically when someone comes in with unstable angina or a myocardial infarction and we've diagnosed it in the emergency room, well, we're going to get those antiplatelet agents on board. Aspirin and clopidogrel are very common agents we use to stop the platelets from sticking to this ruptured plaque in the coronary artery. Okay, so aspirin is one of the first drugs we give as the patient's coming in. Okay, in fact, the ambulance usually gives aspirin while the patient's being transferred to the hospital. Okay, unstable angina and myocardial infarctions, we can use anticoagulants. Why? We want to stop that blood from clotting on the ruptured plaque. Okay, so enoxaparin, which is injectable into subcutaneously into the abdominal skin, or IV heparin. Okay, so the antiplatelets and the anticoagulants for acute coronary syndrome is, I want to stop more clotting on top of this ruptured plaque, and that's why we're using antiplatelets and anticoagulants. Okay, the vasodilator, so nitroglycerin, why would we use that? Well, if someone still has chest pain, ischemic chest pain, we can give them a tablet of nitroglycerin to try and vasodilate the coronary artery to allow a bit more blood to flow down, and it's going to vasodilate the arteries of the body and reduce blood pressure, so the heart doesn't have to pump against a higher blood pressure. Okay? Don't worry about the right inferior MI part. We'll talk about that in the next module. Okay? Glycoprotein 2B3 inhibitors are really just platelet inhibitors as well. We don't use them very commonly, but they stop the platelets from sticking to the fibrin clot. Okay, so just another antiplatelet agent. Okay, so let's talk about nitroglycerin a bit. So in the top right there, you see that they come as 0.4 milligrams per tablet. And those tablets are meant to go under your tongue. Now, we have nitroglycerin that comes as patches for long-term control throughout the day, right? So it's It's a 10 to 12 hour patch that you put on during the day and you remove at night because you need a nitro-free period of time. Okay. These tablets are used when you get anginal chest pain. So you go up that hill, you get anginal chest pain, you sit down, you can take a tablet. Okay, so there's different formulations of nitroglycerin. In fact, there's intravenous nitroglycerin for, say, unstable angina or an NSTEMI, and we just can't control the pain by giving them tablets under the tongue. We've given them blood thinners and antiplatelets, and we just can't control the pain, and we'll start them on IV nitroglycerin, and we'll titrate it upwards until either their blood pressure starts to get too low, because nitroglycerin does that, or their chest pain starts to resolve. Okay, so let's have a look here. So nitroglycerin tablets that we're looking at here. So we take, the patient takes them while they're sitting. Why? Because it drops your blood pressure and they could fall over. So they sit down, they stop the activity, and they put a nitro under their tongue. Works very quickly. And they can take one tablet every 5 minutes, up to 3 doses. Okay. Now, if the chest pain continues, that's not a good sign, because stable angina should resolve by taking nitroglycerin and sitting down. So they can't keep on doing it all day, right? So that's why it's up to 3 doses, because either their blood pressure is going to drop or something else is going on. Now, if the pain is not relieved by having sat down and taken one pill, you can still take up to 3 doses, but it's probably a good idea to contact the ambulance, because you're sitting down, you've taken your tablet, and it's still persisting, right? So that's a bit more concerning, especially if you're used to your angina disappearing after one nitro pill. Okay. You can also take nitroglycerin when you think you're going to exert yourself up the hill. Well, you could take a dose before going up the hill. Okay, it might prevent the exertional chest pain. Okay. Now, for prevention, so I mentioned nitroglycerin comes in a patch, and yeah, you can only wear the patch for 10 to 12 hours. Okay, and then it's to prevent chest pain, anginal chest pain, from developing in the first place if you're wearing the patch. But then it has to be removed. Otherwise, your body gets really used to the nitroglycerin and it's not as effective. So that's why you need that 10 to 12 hour nitro-free period of time. Okay. So don't get confused. We're talking about 2 different uses of nitro. The ones that go into your tongue is where you've exerted yourself, you have chest pain. I want something to relieve my chest pain. I'll take a nitro under the tongue. Nitroglycerin patches, they also come in long-acting pills, are taken regularly throughout the day to prevent the onset of anginal chest pain. Okay, and that's where it's saying you can only have it every 12 hours. That's usually referring to the fact that you have a patch on, a nitro patch on, and you need to remove it after 12 hours to have a nitro-free period of time. So erectile dysfunction medication. So that's referring to sildenafil or one of the other medications in that group. So that's Viagra. So sildenafil can cause your blood pressure to precipitously fall, especially with nitroglycerin on board. So that's an absolute contraindication. If you're using sildenafil, you can't take nitroglycerin. Okay? The 2 combined are not a good idea because of very severe hypotension. So this little nitro bottle that's used, that you'll have in your pocket for going up a hill, needs to be stored in a dark, dry place. When we give someone nitroglycerin tablets for chest pain, for anginal chest pain, We always tell them, you're probably going to get a headache with this. Why do you get a headache? Because of vasodilation in the cerebral vessels. So you don't only get vasodilation of your coronary arteries, you get a pounding headache because of vasodilation in the brain. Okay? And the other side effect is if we give enough of these tablets, hypotension. Okay? And that's why people should really only take up to 3 doses. So what are the types? Well, the sublingual tablets, that's for angina, right? I have chest pain now, I want to take a tablet, okay? The ointments and the patches are for prevention of daytime angina. So you put your patch on in the morning, you remove it at bedtime. Why did you do that? Because you wanted to prevent angina from coming in the first place. And that's what the patches are by far the most popular forms now for long-term control of angina in terms of nitroglycerin. Okay, those patients can still have nitroglycerin tablets in their pocket, and they could take it if they needed to for an anginal episode. Okay, nitro tablets are usually just stored for 6 months, and then they need to be replaced. There's actually nitro sprays now that instead of putting a tablet under your tongue, you can spray under your tongue. And the sprays tend to last much longer than 6 months. Okay, so let's talk about some other therapeutic procedures for myocardial infarction. Okay, so we can talk about thrombolytic therapy, which is administering a thrombolytic or what's called a fibrinolytic. And that's a medication such as TPA, right? Alteplase. There's invasive coronary artery procedures. We've already spoken about some of those at the beginning of this module. So PCI, where you insert a catheter in the radial artery or the femoral artery, and thread the catheter up to the coronary arteries. We can do an angiogram that way, so we squirt some dye into the coronary arteries to see the anatomy of the coronary arteries. And we can also see blockages of the coronary arteries, right? So occlusions. And if there's an occluded artery, it can then be treated with angioplasty and stenting, okay, where they put a metal stent across the blockage once the balloon angioplasty has removed the blockage, okay? So that all can be done percutaneously. So that's PCI, okay? And then finally, coronary artery bypass graft. We'll talk about that. Actually, I have a slide on both of these, so there'll be more detail about coronary artery bypass. Okay, so thrombolytic therapy. Okay, so what is thrombolytic therapy or fibrinolytic? Same term, right? So that's administering a drug such as TPA that has the ability to break down clots anywhere in the body, right? So it's a fibrinolytic. It breaks down fibrin clots. So whether that's in a coronary artery or in the brain or in your stomach, it doesn't care where, it's going to break down fibrin clots. So we use this for STEMIs, right? So for a heart attack, and in particular a STEMI, not an NSTEMI. And typically we'd like to get in the fibrinolytic as soon as possible. So usually we try to get it in within 20 to 30 minutes. Okay, we can use it up to hours later. We prefer that it's being administered up to 6 hours of someone having chest pain. But when someone presents with chest pain, we try to get this medication in within 20 to 30 minutes. Okay, so only for a STEMI. Okay, typically you try to get it in within 6 hours of the person having chest pain. Okay, I mean often they stay at home for the first 5 hours, so that may not always be possible. And let's talk about what it does. So it's going to go intravenously. It's going to travel to to all the arteries in the bloodstream. But in particular, we're looking at the coronary artery, and it's going to break down that fibrin clot that formed on top of the the ruptured plaque. Okay, so the ruptured plaque was the initial event, and then the blood clotted on top of it. So we're breaking down all that clotted blood, hoping to open up the artery, and it works in about 60 to 70% of treatments, right? So let's look at the contraindications to giving someone a fibrinolytic while they're having a STEMI. So any active bleeding. Okay, so if they're having rectal bleeding or they're bleeding from a peptic ulcer, they can't have a thrombolytic. They're going to bleed out if that happens, okay? Any significant known bleeding disorder. So if it's a hemophiliac, or if it's someone with extremely low platelets, or someone who's on warfarin and their INR is high, okay? So an INR greater than 1.5 while you're on warfarin is a contraindication to using a thrombolytic because of the bleeding risk. Always think of bleeding with thrombolytics as the contraindications. If there's a history of a hemorrhagic stroke, so if you've had a history of a hemorrhagic stroke, can't receive a fibrinolytic, such as TPA. History of abnormal blood vessels in the brain. So some people are born with abnormal blood vessels in the brain called AV malformations. They can bleed easily. We wouldn't use TPA. Any recent surgery or any recent significant trauma is a contraindication to using TPA. Uncontrolled hypertension, so a blood pressure of greater than 180 systolic, we don't use TPA. Okay, we can sometimes try and get it down, but usually we just don't use it because TPA combined with severe hypertension can lead to a massive stroke. And of course, pregnancy. Pregnancy because we can cause bleeding within the placenta. Okay, and that can cause separation of the placenta. Okay, so always think of bleeding complications when we're giving a fibrinolytic. Okay, peptic ulcer disease, history of bleeding, history of hemorrhagic stroke, recent surgeries, recent trauma, okay, anything like that. So under nursing considerations, so we definitely minimize the number of times the patient's skin is punctured for blood tests because all those sites are going to ooze, right? We try to avoid intramuscular injections because they're going to bleed into the muscle from TPA, right? We try to start all the IV lines before administering the fibrinolytic, okay? So that we don't have to poke them after their blood has become incredibly thin, okay? Now, when we give TPA for a STEMI, it can take 20, 30, 40 minutes to start working. And often we know it's starting to work because on the cardiac monitor, we're starting to see some irregular rhythms. And those are called reperfusion rhythms. What it means is the blood is starting to flow through the coronary artery again. And the heart is irritable, but it realizes it's getting blood again, and it's throwing off some extra rhythms. Those are really good. Okay, that's a good sign. Okay. Now, we also do repeat ECGs very frequently, looking at the ST segment elevation to see if it's slowly resolving and it's coming back down to normal, right? We're going to monitor for signs and symptoms of bleeding from anywhere because they can bleed anywhere. They can bleed into their brain, they can bleed into the gastrointestinal tract. So we'll do serial hemoglobins to make sure they're not becoming anemic, and we'll ask them about symptoms of bleeding. Okay. Now, if someone were to have a major bleeding event, while receiving a fibrinolytic, well, we would definitely stop it, and we would stop any other anticoagulants as well. And if it's an area where we can apply direct pressure, then we will. Okay. Now, with minor bleeding, say in the tissue or puncture sites, sometimes we can just put pressure on it and hold it, and continue on with the fibrinolytic, because it's a pretty important drug. It's trying to open up an acute coronary occlusion in a STEMI, so it's pretty important. Remember, we used fibrinolytics when we're typically greater than 120 minutes from getting a patient to a cath lab and getting a catheter inserted into an artery so that they can do a PCI. Okay, so these are used much more in rural centers compared to urban centers where they go directly to the cath lab. Okay, so let's just talk about a couple of invasive cardiac procedures, and they're all done frequently, right? In actual fact, the peripheral bypass graft isn't really a cardiac procedure, but we're going to talk about it anyways. So the first one is percutaneous coronary intervention, PCI. So what's a PCI? So the idea is to thread a stent into an artery. So it could be your radial artery, it could be your femoral artery. Okay, actually, radial arteries are becoming more and more used because femoral arteries get infected more frequently. Either can be used. Okay, so what's the purpose of this? Well, they're going to thread up this catheter all the way up the aorta to the coronary arteries that come off the aorta, and then they're going to get into the left and right coronary artery. And what can this catheter do? Well, it can break up a plaque in a coronary artery that's causing the symptoms for the patient, such as angina, or unstable angina. They can place a stent across the area that's just been opened up to stop it from closing in and re-stenosing. Or they can go through the plaque and blow up a balloon and squash all the material against the coronary artery lumen. Okay, and this clears the artery. Okay, and typically after that's called an angioplasty, and typically after angioplasty, you have a stent inserted at the same place. Okay, so PCI can be done electively, say for someone who's not in having a heart attack and they have stable angina, and after a test they can see that they have a really blocked coronary artery, or it can be done emergently in the setting of, say, a STEMI. Okay. So now, in the setting of a STEMI, what's the idea? So someone's having a heart attack, and if the patient is within 60 to 90 minutes of getting to a cath lab, and they can put in they can do a PCI and thread the catheter up to the coronary arteries and perform an angioplasty and a stent. Well, that's what they'll do. They'll just bypass the emergency room. If it's in a rural setting and someone comes in with a STEMI, then that's typically an indication for a thrombolytic and then transfer to a cath lab after receiving the thrombolytic. Okay, we know that thrombolytics are very effective, and if you're beyond about 120 minutes from the cath lab, we'll use the thrombolytic. Okay. Okay, so what are complications of a PCI? Okay, so whether it's going through the femoral artery or the radial artery to get to the proximal aorta, and then to get into the coronary arteries and perform angioplasty or a stent, well, you could tear the coronary artery, right? You could perforate the artery with the catheter, and that could lead to cardiac tamponade. or it could lead to damage of the coronary artery and full blockage of the coronary artery that may result in a heart attack. Okay, so pretty significant complication. Very small though. So cardiac tamponade, we've spoken about. If you were to develop cardiac tamponade, that's basically fluid or blood around the heart. It's squashing the heart because the pericardium can't expand very much. So as that blood surrounds the heart and starts to squash it, blood can't return back to the heart from the venous system. And then it can't be pumped to the lungs. And it doesn't go back to the left ventricle. So you get hypotension. You get an elevated JVP, so jugular venous distension, because blood can't get back to the heart. Muffled heart sounds, because there's blood all around the heart. So you don't hear the heart sounds as well. Okay. And of course you have tachycardia, because the heart's trying its best to continue to pump out blood. Okay. So let's move on to the next complication, hematoma. So where you've put the catheter in at the artery, the radial artery or the femoral artery, you might get a collection of blood that's leaked out of the artery under the tissue. And typically that needs pressure applied to it, right? Allergies to contrast dye, well, for sure, if you're allergic to the contrast media that they used to look at the coronary arteries, then you're going to get symptoms of an allergic reaction, urticaria, potentially hypotension, tachycardia, chills. Okay, those are all reactions, allergic reactions. Okay. So what can we administer for that? Well, we can administer Benadryl, so diphenhydramine, and if we had to, for anaphylaxis, epinephrine. External bleeding from the insertion site can happen, and that's why pressure is typically applied, right? And the leg of the patient is kept straight if it was a femoral artery that the catheter went into. Now, the other ones I'll just leave to you, the embolism, the retroperitoneal bleeding, because we went through this with other invasive procedures earlier. And let's go on to coronary artery bypass. So this is a pretty big surgery, right? So you're basically bypassing the patient's coronary arteries with new vessels. Okay, and it can be done on one coronary artery or it can be done on multiple coronary arteries. It just depends what the angiogram showed. If there's 2 or 3 blocked arteries, well, they may have to have a triple bypass. So it just depends on how many vessels are blocked. Okay. Now, for this procedure, the patient is placed on cardiopulmonary bypass. Okay, so they want the heart to stop beating, and so they bypass the vessels and put someone on a machine for cardiopulmonary bypass. Okay, and the new vessels for the bypass can come from the leg, so the saphenous vein, or it can come from arteries that are around your ribs. Okay, so a mammary artery can also be used as a replacement. Okay. Now, what happens next is the artery or vein is harvested from the leg or the inner rib cage, and they are anastomosed or attached to the coronary arteries to bypass the blocked areas. Okay. Now, I'm not going to go through all the post procedures because I think it's really well laid out in your book. So there's no sense in me repeating them all here. I'll try and give you the information that's on the slides, but I think the complications and everything are all well laid out in the book. Now, what's a peripheral bypass graft? Well, you have a blocked artery in one of your legs, or say in your arm. It's more common in the legs though. And you need to restore blood flow to that leg. So as we were talking about before, an ischemic leg, right, where there's just so much atherosclerosis and blockage of the artery that the patient needs a bypass. Okay. So what do they do in this case? So they take the graft, and the graft can be part of the patient's saphenous vein, and what they want to do, or just graft material, either one. And what they want to do is they want to go to the artery above the site of occlusion, and they want to suture the graft onto the artery there, and then they're going to go around the occlusion and then suture the graft back onto the distal area past the occlusion. Okay, so that's the whole idea, that you just want to get around this occlusion in the artery so that blood can continue to the limb. Okay, so let's look at PCI a bit more. I know we've spoken about it, but let's look at the indications. So this procedure can be done, as I said, from the wrist or from the femoral artery, and it can be done in an elective way, meaning it's not urgent, but a patient had an angiogram, and it was noted to have, the patient was noted to have blockages in coronary arteries that they could reach with percutaneous coronary intervention, right? So if they know they can reach the blockages with this, then the patient doesn't need to have a CABG, a coronary artery bypass graft, which is a big surgery. Okay, so it can be done electively. They might come back in a week or 2 weeks and have it done. And they'll have angioplasty, so balloon angioplasty that you see in A, where they've put the balloon across it. They'll dilate the balloon and basically crush the plaque or move the plaque against the coronary artery, and then put a stent in. Okay. Now, this can be also done emergently. Okay, so someone comes in with a STEMI, and they go directly to the cath lab and receive a heart catheterization, a left heart catheterization. They look quickly to see what blocked artery it is. They do an angioplasty, and they put a stent, and the coronary artery is open. Okay, so this can be an alternative to using a fibrinolytic. Remember that 120 minutes, right? So if you're 2 hours out, okay, fibrinolytic. If you're in downtown Salt Lake City, direct to the cath lab for a PCI during an acute STEMI. Okay, so and often this can be used as an alternative to a CABG, which is fantastic, right? Remember, a CABG you get opened like a clam, right? They cut right down your sternum, they retract your ribs, they open up your chest wall, and they do cardiac surgery. Okay, so this is much less invasive. Okay, so under types, so percutaneous transluminal angioplasty, well, that's the balloon. That's B, right? Just ballooning the plaque out of the way. And then coronary artery stent placement is C, right? So they put this metal stent right across. And you can imagine if you're getting a metal stent or if you're getting angioplasty, you're going to be on blood thinners after the procedure. You're typically on clopidogrel, which is an antiplatelet medication, to stop anything, to stop the platelets from forming platelet plugs and platelet aggregation on the new stent. Okay? Okay, so think back to the procedure of a left heart catheterization or a percutaneous coronary intervention, right? It's that catheter that's being threaded through your radial artery or your femoral artery all the way back to the aorta, and then it's squirting dye into the coronary arteries to see the anatomy and the blockages of the coronary arteries, and then potentially performing angioplasty and insertion of a stent. So Let's look at the complications on the right. Myocardial ischemia. Well, if the stent gets blocked as soon as you remove everything, well, you could block the artery again. Or see the whole area just blocks back up with clotted blood because it just wanted to. The plaque was still there, and the body decided to clot it all back up. Well, you'll get potentially ischemia or an infarction after the procedure. Okay. What about bleeding and a hematoma? Well, from at the area where you inserted the catheter, you can have bleeding, swelling, because you're forming a hematoma, which is a collection of blood under the skin. And what can it be from? Well, these patients are often on anticoagulants after the procedure, such as clopidogrel. They've had the artery punctured. Maybe they moved their leg after the procedure. Maybe there wasn't enough pressure on the artery, and now they have bleeding or a hematoma at the puncture site. Okay. Retroperitoneal bleeding is where this is where the femoral procedure, where they put the catheter in the femoral artery, and it's caused a leak in the retroperitoneal space, so at the back of the abdomen, and they develop bleeding. So how are they going to present? Well, flank pain, abdominal pain, hypotension because they're losing this blood into the abdomen, and tachycardia, right? That's going to be an absolute emergency. Luckily, it doesn't happen very often. The anticoagulants will need to be stopped. IV fluids will need to be started because of hypotension. An immediate CAT scan of the abdomen to see if there's bleeding there. And they'll likely need some kind of surgical intervention looking for the leaking artery. Okay. Arterial occlusion. Well, you could get an arterial occlusion where you actually punctured the artery. So say at the radial artery, right? Or the femoral artery, because you actually injured the artery by puncturing it. And it could lead to a blocked ischemic leg or an ischemic hand, okay? Because the artery is completely blocked. So remember your 6 P's that can happen. So that becomes an emergency because they have an ischemic leg or an ischemic hand, potentially. What else? Let's go right to acute kidney injury. So this is from the nephrotoxic contrast media for looking at the coronary arteries that they squirt in. And what happens? Well, the contrast media can be nephrotoxic, and it can cause intrinsic renal injury to the nephrons and result in elevated BUN and creatinine. Now, typically, the kidneys are pretty tough, and with IV fluids and maintaining good urine output, they usually recover. Okay. Now, sometimes, if we know that someone has weak kidneys to begin with and they're undergoing this procedure, acetylcysteine, which is used for acetaminophen overdose. It's used as a mucolytic to break up thick secretions as a nebulizer in the lungs. It's also been shown to have protective renal effects from contrast media. So sometimes this is given to protect the kidneys from the contrast dye. Okay. Okay, so I'm not going to spend too much time on this slide. So pre-procedural. Now remember, a PCI is sometimes done in an emergency, a STEMI. So it's not always possible to be NPO for 8 to 12 hours. But if it is, if someone's coming in electively for angioplasty and a stent insertion, then it is possible to fast and not eat or drink for 8 hours, right? Checking allergies, especially to contrast dye, seafood, iodine, We often check their serum B1 and creatinine, make sure that they're good. Some patients may receive acetylcysteine if they have renal issues to begin with, or antihistamines if they've had a rash previously with contrast dye. Post-procedurally, it's all about, well, it's two things. It's the heart that's had a procedure to it, such as angioplasty. So they're going to be on a monitor looking for arrhythmias, right? The patient's going to be asked, do you have any chest pain? Are you short of breath? Because remember, that stent or the angioplasty can restenose and block up, and the patient can have new onset of chest pain again, right? So they're on a monitor looking for arrhythmias, and they have, depending on where the catheterization was done, they may have a TR band, which is an inflatable wrist band to compress the radial artery, or a fem stop right over the area to control any bleeding at the femoral artery. So pretty cool devices, and nobody has to hold the site, or the patient doesn't have to hold the site. So they're super useful, right? Typically, patients are on antiplatelet medications after this procedure, right? You don't want the angioplasty or the stent to reclot up. So antiplatelets are used. Sometimes anticoagulants are used after the procedure, such as IV heparin, to stop any coagulation. Remember, antiplatelets stop platelets, right? Aspirin and clopidogrel. Anticoagulants stop the formation of the fibrin clot, right? Because of the coagulation cascade. So that's heparin or enoxaparin, okay? If the femoral approach is done, it's 6 hours of bed rest, 6 hours of keeping your legs straight, and you're usually supine, or the head of the bed is less than 30 degrees, okay? So I think that's it for this slide. Let's move on. Okay, so I won't spend too much time on a CABG or a coronary artery bypass graft. It's a pretty significant surgery. I'm going to tell you, with more and more PCI being done, you don't see as many patients going for CABGs as we used to years ago, okay? And there's two ways of doing it. There's stripping a vein from your leg, which is the saphenous vein that you'll see in the top right there, a saphenous vein graft, or they can take the internal mammary artery, which is your inner chest. Your inner chest wall has arteries, and they can graft it right onto the heart, okay? So there's two separate options to do, and it's all about bypassing the blockage, okay? The cardiopulmonary bypass machine, by the way, I'm sure you know that you're not awake for this, right? Because they've cut through your chest, your sternum, they've cut right through the bone, they've split open the chest, they've used a rib spreader to move everything out of the way, so they have full exposure of the heart, right? So the cardiopulmonary bypass machine, so the lungs, it stops the lungs and heart, okay? So that's great, because now the heart can be operated on, and it's not continually pumping. And it's taking blood from the venous system, so the bottom right here, taking blood from the venous system, going through a pump, and putting it into the arterial system. So the coronary arteries are still being fed with blood, okay? So it basically does the work of the lungs, so it reoxygenates, and it does the pumping of the heart, right? While the heart is stopped. What are the complications? Well, you could have a hemorrhage, right? So this is not a normal way that our system is made. So there could be a leak somewhere. You could have hemorrhage. Arrhythmias are always possible, because the heart is very sensitive to changes, especially surgical procedures. You could have an MI during the surgery, because the they're opening up vessels and applying grafts to them. So any injury to a vessel could lead to an occlusion, right? Arteries don't typically like to be touched. Okay, so let's go on. I won't spend too much time on this. This is coronary artery bypass, but it's an alternative way. So it's an off-pump coronary artery bypass. So it uses beta blockers to really slow down the pumping of the heart. And then there's a device that's going to hold the heart with some degree of stability. And they'll do the surgery while the heart is pumping. Okay, it's just pumping slower. So there's no cardiopulmonary bypass with this procedure. Okay, so let's do the questions at the back of the chapter. And this is chapter 31. Okay, so number 1, a nurse is admitting a client who has a suspected myocardial infarction and a history of angina. So he's got a history of angina, but now he has a suspected MI. Okay. Which of the following findings will help the nurse distinguish stable angina from an MI? Okay, so let's go back and remember, stable angina is a stable plaque. It's not getting bigger, it hasn't ruptured, it's very predictable in the symptoms. So I go and exert myself if I have stable angina, and the heart needs more oxygen supply, but it can't give it. So the heart is asking for more, so more demand, but the coronary arteries can't supply more blood flow because of the stable blockage, and you get angina, chest pain. It goes away when you rest and when you take a nitro pill. Okay, so let's look at the answers. So stable angina can be relieved with rest and nitroglycerin. That's true, right? That's totally true. Stable angina can be relieved with rest and nitroglycerin. And that's the big difference between stable angina and unstable angina, which is rest pain, unpredictable chest pain, frequent chest pain, and often it's just not related to exercise at all. It's just happening on its own accord because the plaque has ruptured. Okay, so A is correct. B, the pain of an MI resolves in less than 15 minutes. That's not true, right? The pain of an MI can last for hours. It doesn't usually last for days. Usually you wouldn't survive if you had myocardial infarction, chest pain for days, but it definitely lasts longer than 15 minutes. So B is not true. The type of activity that causes an MI can be identified. No, the type of activity that caused the MI, in fact, you don't even have to be doing an activity to get a plaque, a ruptured plaque. This could happen in your sleep, right? So a ruptured plaque or a complicated plaque could happen at any time of the day. Stable angina can occur for longer than 30 minutes. No. Stable angina resolves really quickly when you sit down, plus or minus taking a nitro tablet. So the answer is A. 2, a nurse on a cardiac unit is reviewing laboratory findings of a client who has a diagnosis of myocardial infarction. Okay, and reports that his dyspnea began 2 weeks ago. Which of the following cardiac enzymes would confirm the MI occurred 14 days ago? Okay, so a nurse on a cardiac unit is reviewing the laboratory findings of a client who has a diagnosis of a myocardial infarction and reports that his dyspnea began 2 weeks ago. Okay, so the only one that's going to last that length of time is going to be troponins, right? So CKMB usually lasts a couple of days and it's gone in the bloodstream. Myoglobin lasts typically 24 hours and it's gone. So this is a bit of an unfair question because both of those troponins last a long time. So troponin T lasts a bit longer, 10 to 14 days, versus troponin I lasting 7 to 10 days. So it's going to be troponin T. I don't like that question. That's not really testing you on anything. Okay, number 3, a nurse is caring for a client who asks why the provider prescribed a daily aspirin. Which of the following responses should the nurse make? Okay, so someone's been given a daily aspirin, but it doesn't say why. So we're going to assume that it's for coronary artery disease, atherosclerosis. Aspirin reduces the formation of blood clots that could cause a heart attack. Okay, so aspirin does reduce platelet aggregation, which is part of a blood clot. So that's true. Aspirin relieves the pain of myocardial ischemia. No, a nitroglycerin tablet could. Aspirin dissolves clots that are forming in your coronary arteries. No, it doesn't. It's an antiplatelet. It stops aggregation of platelets. So it stops the building of a clot, not the breakdown. It doesn't dissolve clots like TPA or any fibrinolytic. Aspirin relieves headaches that are caused by other medication. We don't really use it for that, so I think they're getting at the fact that nitroglycerin can give you a pounding headache. But we don't usually give a daily aspirin for headaches, right? So they're saying that the person is prescribed a daily aspirin. Well, it's to reduce the formation of blood clots. So A. Number 4. A nurse is teaching a client who has angina about a new prescription for metoprolol. Which of the following statements by the client indicates understanding of the teaching? Okay, so let's have a look. I should place the tablet under my tongue. No, metoprolol doesn't come as a sublingual tablet, right? It comes orally or it comes intravenously. I should have my clotting time checked weekly. No, this is a beta blocker, so it's going to block the sympathetic nervous system. And what we're trying to achieve here is a lower heart rate and reduced contractility of the heart so that we can rest the heart during angina or after a heart attack. I will report any ringing in my ears. No, metoprolol doesn't give you ringing in your ears. I mean, so there are drugs that do give you ringing in your ears, like high-dose aspirin can give you ringing in your ears. Aminoglycosides like gentamicin or vancomycin can give you ringing in your ears, but not metoprolol. I will call my doctor if my pulse rate is less than 60. Okay, well, I guess that's the answer. I don't think you necessarily always have to call someone, because some people actually have slow heart rates while they're on metoprolol, and it's kind of expected. But for the purposes of having your heart rate between 60 and 100, that would be the most appropriate one. So D is the answer. 5. A nurse is presenting a community education program on recommended lifestyle changes to prevent angina and MI. Which of the following changes should the nurse recommend be made first? Diet modification. Okay, that's important. You know, people that are on really high-fat diets, high cholesterol diets, relaxation exercises. Okay, that can be done too. You know, relaxation is important to reduce stress and reduce the sympathetic activity that's being triggered in your body, so that's not a bad idea. Smoking cessation, yeah, that's a good idea too. Taking omega-3 caplets, I mean, yeah, sure. I guess, you know, there's some evidence that it might be helpful, but definitely the most important of all of those is smoking cessation. Okay, because smoking has nicotine in it. So not only is it harmful to the lungs because of all the toxins, but nicotine is a powerful vasoconstrictor. Puts your blood pressure up, and it causes coronary artery narrowing, okay, or vasoconstriction. And also, all the toxins in smoking are contributing to atherosclerosis. So, I mean, I think they're all good answers, but the one that you would do first is smoking cessation. Okay, so that's the end of the module. Hopefully that helped with your studying. I think the combination of going through the slides with a voiceover and having your book with you, I think that combination is going to really make you strong for exams. And if you have a good understanding of this material, some of it will stick going forward. Okay, not everything sticks. Some of it leaks out for sure. But using the book and these PowerPoints with voiceovers, I really think you'll get a good basis going forward. Okay. If there's any questions, just ask. Okay. Don't leave things. Don't let things pile up in the corner, and then there's lots and lots of questions that are building up and snowballing. Okay. So just ask questions of your instructor, and if your instructor isn't sure, they can always check. Okay, and get back to you, because it's impossible to know everything. So remind yourself of that. It's impossible to know everything. And that way you can go a bit easier on yourself, because it can be stressful if you think, I need to know everything. And you just can't do it. There's too much. Okay? So things come with time. See you at the next module.